Dear colleagues, it's my great pleasure to welcome everybody to our Myopia meeting this year, Myopia 2024 Innovations. This meeting is organized by Foundation Ophthalmology 21 with the collaboration with the University of Warmia-Mazur in Poland and Ministry of Education and Science in Poland. This is the meeting got the sponsorship and support from the important companies, including EssilorLuxottica, Santen, Oculus, Hoya, Hack, Stride, and Cooper Vision, and we are very grateful for their support to this meeting. And finally, we have also media patrons. This is the magazine The Ophthalmologist and the Polish medical platform Medycyna Praktyczna, which means practical medicine. The meeting is co-organized by our group. It's this European Network for Myopia Prevention and Control. This group invites European ophthalmologists and optometrists and experts interested in myopia prevention and control. And we work now on the different subjects like using AI in myopia and the risk calculator for detecting myopia. We invite everybody interested to join. You can join via our website that is shown here. The website is partly in Polish. This is the website providing information for parents and professional experts on myopia in Poland. But we do have also some we have also in the upper part of the website the subheading European Network. You can use this, and this is in English, just to register and be involved in our group. I would like to also mention that we organize also very interesting meeting soon in 2 weeks on artificial intelligence in ophthalmology. Again, you are welcome to register and join us at that day. Today we have a honor and the great pleasure to have with us as the special lecturer for opening lecture, Professor Mark Ballymore, who will speak on the future of myopia control. Professor Ballymore is an internationally renowned scientist, speaker, educator based in Boulder, Colorado. He received his optometry degree and PhD in vision science from Aston University in Birmingham, in England. He spent most of his career at the Ohio State University and the University of California at Berkeley, and is now adjunct professor at the University of Houston. He is the former editor of Optometry and Vision Science. His expertise is in myopia, contact lenses, low vision, presbyopia, and refractive surgery. And that means that he is a consultant for a number of ophthalmic surgical and pharmaceutical companies. This work has resulted in approval, among others, of Paragon CRT, Alcon's iLux, and Cooper Vision MiSight lens. He has co-authored over 100 peer-reviewed scientific articles, including several modern classics in the field of myopia control. So now we are happy to listen to the lecture of Professor Ballymore. After the lecture, we'll have a short discussion, so everybody is welcome to put the questions on the chat, please.
Thank you very much, Andres. It's my pleasure to be here and to talk to you today on the future of myopia control and the questions that should be answered. Before I begin, I would like to disclose that I'm a paid consultant for a number of companies. And I also want to acknowledge the contributions of my friend and collaborator, Noel Brennan, in some of the thoughts and ideas that I'm presenting to you today. So question one, why myopia? Why now? Well, we used to regard myopia as a benign refractive condition that we could treat with spectacles and contact lenses, but our perspectives have changed for a number of reasons. Its increasing prevalence, particularly in East Asia, the fact that we now have a better understanding of the role that myopia plays in uncorrectable visual impairment, and the ability that we now have to do something about it. The second question is, what is the public health benefit of myopia control? And we published this paper a few years ago where we identified 3 long-term benefits of lowering a young patient's ultimate level of myopia. But the most important one is the one at the bottom, the reduced risk of visual impairment associated with higher levels of myopia. So we took data from a number of studies where the prevalence of myopic maculopathy had been reported as a function of the level of myopia. And we were able to replot those on a logarithmic scale, and we were surprised to observe that they all had a very similar slope. That slope was on average 1.67. So what that means is that each diopter of additional myopia increases the risk of myopic maculopathy by 67%. Likewise, each diopter less, each diopter, if you like, we could prevent, reduces the risk by 40%. So we revisited this in a subsequent paper, which I'll talk about a couple of times in this presentation, where we explored the issue of visual impairment. And in that paper, we used data from the Netherlands, where a combination of studies provided about 15,000 patients or individuals who had both visual acuity data and refractive error data. And this is what those original data look like from that particular paper. We replotted the cumulative risk of visual impairment on a logarithmic scale as a function of the level of myopia for different age groups. And you can see the lines are fairly parallel, and the average slope of those lines is 1.3. So each diopter of additional myopia is associated with an increased risk of uncorrectable visual impairment by about 30%. Likewise, each diopter less reduces the risk of uncorrectable visual impairment by 25%. So we've explored this recently in this article on the right, where we looked at the role that myopia plays in uncorrectable visual impairment in the United States. And you can see, regardless of the level of myopia, the influence of myopia on visual impairment is quite pronounced, and obviously it increases with increasing levels of myopia. So assuming a global prevalence of 50% in the year 2050, there will be over 300 patients visually impaired using a criteria of 612 or 0.5. And of those, 35% of all of those cases will be attributable to myopia. And preventing one diopter of myopia or slowing myopia by one diopter, even if we target just the very high myopes or those destined to become high myopes, we can make a very dramatic impact. And even if we can slow all myopia by one diopter, we can make an even more dramatic impact. Well, the next question is the benefit of myopia control worth the risk? And we have a number of myopia control options, and you're going to hear about these today. But in terms of the risk versus benefit, we looked primarily at soft contact lenses and overnight orthokeratology. And in these two papers, and I'll share a link to the references later, we found, first of all, that microbial keratitis was really quite rare in children wearing soft contact lenses. And looking at a range of prospective studies, the overall incidence is less than 3 per 10,000 patient years. And you can see that in 6 of the 7 studies, no cases were reported at all. Well, what about orthokeratology? Well, we conducted this retrospective study over 10 years ago on both adults and children. And based on over 25,000 patient years, we identified 2 cases of microbial keratitis, both of which occurred in children. Now, neither of these resulted in any loss of visual acuity, but we can estimate the incidence as around 14 per 10,000 years of wear. Now, since then, we've conducted another study using children in Russia, and the study identified all episodes of infiltrative keratitis in children in 2018. And during that year, there were over 130 cases, of which 45 were adjudicated by 3 medical doctors to be microbial keratitis. And 5 of those had occurred in overnight orthokeratology wearers. So estimating the number of children wearing lenses to be around about 10,000 in 2018, we can estimate, based on those 5 cases, that the incidence is around 5 per 10,000 patient years. So in summary, the incidence of microbial keratitis is somewhere around 1 to 3 in daily wear soft lenses for children, and maybe 5 or 14 per 10,000 for overnight orthokeratology. Remember, these are unilateral events. And in this particular paper, which again I would refer to you to for more details, we came to the conclusion that the benefits of myopia control far outweigh the risks. And we were able to calculate the years of vision loss prevented by a diopter treatment to be somewhere between 5 to 10,000 per 10,000 patients. In contrast, the years of vision loss accrued by 5 years of treatment per 10,000 patients is an order or 2 of magnitude lower. The next question is, how do we describe efficacy of myopia control? And in this paper that we published a few years ago, we argued that axial length was the preferred metric to study efficacy. One reason for that is it's far more repeatable than measures of refraction, even when you're performing cycloplegic autorefraction. And of course, it's also more important because it relates more to visual impairment than does refractive error. The second reason that we should use, or the second way we should describe efficacy, is to use absolute reductions rather than percentages. And we demonstrated that from a number of studies. And you can see here from this study of myopia control using soft contact lenses that the 2 lines plotted as a function of age, the treated children at the bottom and the untreated children at the top, the lines are parallel, suggesting that the efficacy in millimeters is constant across age. If you use percentages, those numbers down the bottom there in red, the percentage efficacy you get is very different in the young children compared to the oldest children. And we've since done a subsequent analysis using the LAMP study, And what you can see here is the change in refractive error for the children receiving 3 different concentrations of atropine or the control children. And you can see again that those 4 data sets are parallel. The ratio, the effect of different concentrations is independent of age when you're considering millimeters or diopters as your measure of efficacy. If you use percentages, you can again be misled. The percentage treatment efficacy for the highest concentration of atropine is about 40% in the youngest children, and it's 130% in the oldest children. But if you use millimeters, you get a constant treatment effect across ages, and as we've shown in other studies, constant treatment effect across different races. The other thing that's important to remember is that the efficacy is highest in year 1 and about 50% less in subsequent years. So you shouldn't extrapolate the efficacy from the first year to years 2, 3, and so on, because it's going to be less in those subsequent years. And as you can see here, all of these lines have a sort of dogleg shape, showing that the reduction in axial elongation is greatest in the first year. We showed this in a subsequent paper where we plotted the year 2 reduction in axial elongation against the year 1 elongation. And the slope of that curve, slope of that line is about 0.5. So again, the efficacy in year 2 is about half the efficacy in year 1. The other thing that's important to remember, getting away from efficacy for a minute, is that axial elongation slows with age. So when you look at the youngest myopic children, they are progressing and elongating much faster than the oldest. And across races, there's about a 15% reduction per year amongst untreated myopes. And now, just finishing and staying with untreated myopes, we've also looked at the ratio of progression in diopters to elongation in millimeters among untreated myopes. And that ratio is around about 2. It is not affected by race, and it doesn't seem to be affected by the age of the children either, although that ratio may go up at older ages. So the next question is by what amount can we realistically reduce myopia progression? So again, I'm going to focus on axial elongation and show you some examples just on this one slide of different modalities and their differing efficacy. The one at the top is from a paper on red light therapy, and you're going to hear a little bit that later. The red dotted line is for 0.05 atropine, 0.05% atropine, but you can see down the bottom, 0.01% is much less effective. And then in between, we have myopia control spectacles, overnight orthokeratology, and dual focus soft lenses. And I'm focused here on studies where we have at least 2 years of data. So we have a number of treatment modalities that work, and we can see over 2 or 3 years the extent to which we can slow myopia progression. We've got a number of options down the bottom, including 0.01% atropine and progressive addition lenses, spectacles, that don't work as well. But we should remember, of course, that there are other considerations beyond the efficacy. So we get to be the doctor and choose among our efficacious treatments that best suits the child. And the most important of these is compliance, because without compliance, you're not going to get good efficacy. So the next question is, when should we begin treatment? Well, this is where I think some of our colleagues have got it wrong. because in this survey of pediatric ophthalmologists, the primary criteria for initiating treatment was the rate of myopia progression in children or in an individual child. And indeed, in another survey here in Singapore, 2/3 of the practitioners did not initiate myopia control interventions because they didn't know what the progression was in that patient. Well, I think that's foolish for a number of reasons. First of all, we know that myopia generally progresses. So if you look at the gray bars on this graph, you can see the 3-year progression in the children who are in the control group. And almost without exception, those myopic children progress. Likewise, in this assessment of predicting future progression, you can see that there's really no relationship between progression in 1 year and progression in the 2nd year. Okay, the predictive power of this is very weak. So I think what I would encourage you to do is to not wait. If you have a myopic child, clearly they've developed myopia, and the high probability is that their myopia is going to progress. So we should treat all of them immediately. Now, the next question is, what is normal progression? Well, the most important determinant of the rate of progression is age. So these are data from the COMET study. And you can see at the top, the slowest progressing children are the oldest children who are 11 years of age. The fastest progressing children are the 6 and 7-year-olds down the bottom. And there's almost a factor of 2 or 3 between those rates of progression. And we have tools available to us like the BHV myopic calculator. And this allows you to put in the age of the child and predict, if you like, their future trajectory, their future progression. So that's very useful for talking to a parent and telling the future in terms of the progression of myopia. There's also charts available. This is one example showing the annual rate of progression in both Asian and non-Asian children for both axial length and refractive error. The next question is, when should we discontinue myopia control? Well, we know a lot about myopia stabilization, again, thanks to the COMET study, and they reported in this paper long-term follow-up on over 400 myopic children who'd been followed for at least 11 years and whose stabilization could be established using their curve fitting process. And what they found is that 50% of the children stabilized by 15 years and 75 stabilized by 18 years. But of course, that's only half the story. What that means is that 50% of these children are progressing beyond the age of 15, and 25% are progressing beyond the age of 18. So there's a lot of variation amongst children. So we have to make individual measurements of their ongoing progression and axial elongation and make an individual decision. So my penultimate question, I think, is, what are the effective ways to delay myopia onset? And the question I want to ask as a sort of sub-question here is, why would we want to delay onset? Well, when you look at the relationship between age of onset and the final level of myopia, you can see that earlier onset myopia is associated with higher levels of myopia later in life. And we took these data from this study and a number of other studies to look at the relationship between the final level of myopia and the age of onset. And you can see here in these Asian children that the slope of these lines is about 3/4 to a diopter per year. So what that means is you can if you delay myopia onset by a year, you can potentially save or prevent up to a diopter of myopia ultimately in later life. And that, of course, is very meaningful compared to what we can achieve by slowing myopia progression in an individual year. Now, how might we delay onset? Well, we know that outdoor time is important, and the more time that a child spends outdoors, the lower the likelihood is that they will develop myopia. And that is independent of the number of myopic parents that they have. We can also use atropine. So these are some very nice data from a recent randomized clinical trial where over 400 children were randomized to either nightly 0.5% atropine, nightly 0.01% atropine, or a placebo. Over 2 years, about half of the placebo children developed myopia. And remember, this is a group of non-myopic children with initial refractive errors between plano and +1. But with the 0.05% atropine at the bottom, you can see that only about a quarter of the children develop myopia. And you can look at this another way by looking at the time to myopia onset, or these survival curves. And basically, the 0.05% atropine delays onset by around about a year. So my final question is, what are the barriers to myopia control? And there's been some analysis of that within the UK and Ireland, with the suggestion that workforce or the availability of clinicians to manage myopic children may severely hamper the ability of us to get a hold of this myopia problem. There's other countries like France, where there's already a shortage of ophthalmologists who will see children, and that's only going to get more acute as we get into this age of myopia control. There are also regulatory hurdles, and it doesn't matter where in the world myopia control is being conducted. In some cases, like in Europe, the path to approval of products, be them lenses or drugs, is relatively short. But in other parts of the world, like where I live in the US, it can take 3 to 4 years. And then again, there's a number of challenges in conducting myopia clinical trials. Now, first of all, since we can slow progression, is it ethical to withhold treatment for a year or maybe up to 3 years in a myopic child? And then we can suffer from additional challenges like recruiting children withdrawing, or accessing other treatments outside of the trial. So I thank you for your attention. A lot of the papers that I've talked about today can be accessed through this QR code, or you can email me or visit my website where you can also access that information there. So thank you again. I look forward to the ensuing questions and discussion. And I also look forward to what should be an excellent program throughout the afternoon. So thank you.
Thank you, Mark, very much for this great lecture, very informative. We are open for the questions for our attendees, and we wait for the questions in the chat. But in the meantime, let's start discussing some, well, as a matter of fact, I wrote a short question that you have already answered during your presentation. So when do you start treating myopia? And I understand that the answer is whenever it occurs. Yeah, this is the answer. And thank you again for creating this very nice saying. Every diopter matters. I think it's very important for us, all of us. I mean, all over the world.
Well, thanks for your kind words, Andrés. It's 5 a.m. here in Colorado, so I had to get up a little early to talk to you, and I'm already enjoying some coffee. But yeah, I think it's important that we not wait when we have a myopic child in front of us, because myopia is never going to progress as fast as it is in that subsequent year. But I also think if we do have children who are at risk of developing myopia and we have concerned parents, then we need to engage in myopia prevention as well, be that lifestyle changes or potentially prophylactic atropine. So I think we need to start right away, but we also can start earlier in a high-risk child.
So thank you even more for being with us in this very early time in your place. What do you think what we can do to delay the onset of myopia? I mean, when you start with this topic, I mean, as I understand, your perspective is that when you have a myopic child, then you of course start the treatment. But how we can predict, I would say, obviously, not every non-myopic child should be treated. So how to differentiate between those who should be benefit from some sort of intervention, I would say, because of course outdoor is probably recommended for everybody, could be recommended for everybody. But what about more invasive interventions?
That's a great question. So Carla Zadnik and colleagues have looked at the risks or the predictors for developing myopia. And the single best predictor is just a simple measure of refractive error under cycloplegia whenever you see the child. And in a 6-year-old child, if the child has less than 3/4 of a diopter of hyperopia, they should be regarded at risk. Now, even then, you might not want to treat all of those children because the probability of a given child becoming myopic will depend on other factors. And they've just published a very nice follow-up paper where if you look at, these are North American children, if you look at an Asian American girl at the age of 6 with half a diopter of hyperopia, they have an over 50% chance of becoming myopic by the age of 14. In a white boy, that risk is closer to 10%. So you need to consider these other factors, I think, before deciding who to treat. And certainly treating everybody is not a cost-effective or a reasonable evidence-based approach.
Regarding the, let's say, background issue of the, let's say, prevalence of myopia in different parts of the world, we do have such a some sort of the controversy in Europe on this topic, I would say. So in some countries, it is not very clear that we faced a real, let's say, increase in the prevalence of myopia, well, including Finland, Germany, recent paper from Switzerland. So what do you think about that? I mean, how we can discuss this at first? Well, there are not so many differences, I would say, between our countries like France and Germany and Poland, for example, in the lifestyle and well, education or whatever, and also time outdoor. And so on. Also, probably Finland is not so different in that way. But of course, on the other hand, we do not really have a very strong epidemiological studies. I mean, comparing different European countries, at least recent studies. So this is certainly one of the problems. But what do you think about the studies? You know, certainly showing no increase in the prevalence of myopia in Europe.
I think that's partly due to the consistently healthy lifestyle in those countries that you alluded to. So, you know, you go to places like the Netherlands and you see people, be them adults or children, out on bikes, and walk in regardless of the weather, regardless of the time of year. In the US, everybody's in their cars, and in Hong Kong, everybody's in their apartment. So it's a very different culture. It's a very different lifestyle. And I think, the technological advances that have deterred children from going outside in some parts of the world, and the increase in the intensity of the education system that's occurred in China and Taiwan, we don't see those changes so much in Europe. So I think it's, the good news is that myopia may not be increasing in some of these countries. And the second piece of good news is it's sort of indirect evidence that changes in lifestyle and changes in activity, doing more outdoor activity, can have an effect at keeping myopia prevalence stable. And perhaps if you change lifestyle, you may, as they've shown in Taiwan, begin to bring the prevalence of myopia down. So, but that's a very astute observation on your part, Andreas. So cheers.
Thank you. Well, we discussed the, let's say, myopic children. What about adults? As you nicely shown, there is evidence that, of course, against the myth, and what I was taught during university time, that myopia stabilizes during the adulthood and will not progress. We know now that it progresses. So, what can we offer adults? Because as we know, all of the studies are based on the, let's say, children or teenagers. We have no really data how if we can help anyway adult patients with myopia progression.
Yeah. So going back to the slide I showed from the COMET study, the sort of most dramatic feature of those data is that 25% of children are still progressing when they finish high school. So that's the first point. The second is those are relatively young onset myopes. If you look at the recruitment for that particular study, these are myopes who developed myopia typically at the age of 9 or before. So if we had a cohort of patients who, say, developed myopia at the age 11 or 12, then the data might look slightly different. Now, when it comes to addressing myopia in adults and perhaps considering myopia control, somebody like myself who developed myopia at the age of 30 and only developed about a diopter and a half, 2 diopters, that's not the patient that deserves or needs myopia control, because my absolute risk of complications is still very low. The people we need to pay attention to during adulthood are the people who already have significant amounts of myopia, be it 4 diopters, 5 diopters, or above. Those people, if they progress more, there's an accumulation of risk. And Brennan and I have just submitted a paper where we've analyzed the number of data sets, and the conclusion from all 3 data sets, including the NHANES data that Vitali published a few years ago, is that between the ages of 18 and 45, myopia on average increases by a diopter. So we do have to think about, particularly the higher myopes, the benefits or the potential benefits of keeping them under sort of myopia control regimen to slow that down, and even exploring things like hypertensive drugs, glaucoma drugs, because that's often a last resort, but we don't have a great deal of data on those sort of interventions just yet.
Thank you. We have just time for one more question. This is the last question about the, let's say, public education, because well, we all agree that it's important. And so what do you think, what should be the message to the, let's say, parents, children, teachers, related to the myopia awareness, I would say in that way?
I think the first thing is we need to stop thinking of myopia just as a refractive problem and be aware of its role that it plays in problems later in life. We need good messaging to sort of think about these things. The best one I've sort of come across is the analogy of sunscreen. You put sunscreen on a child, and you stop the risk of having a bad sunburn and a very uncomfortable child, but there's a benefit long-term of reducing the risk of skin cancer. It's the same with myopia control. We have benefits in the short term of making them a better candidate for refractive surgery and reducing the level of disability that they have without their correction. But the long-term benefit, again, is the reduced incidence of disease and visual impairment. So we're at such an early stage, and it's due to the work of people like yourself that we're getting the word out there, but we still have a long way to go in terms of our public health messaging.
Thank you. I completely agree. Thank you so much again for the great lecture and very informative discussion. We need to follow to the first session. So thank you again. I will try to thank you. Well, to show, maybe you can, hopefully you can show my screen now, or yeah, is it visible?
We can see your screen.
Okay, great. So now I would like to introduce the session number 1 for today, New Technologies in Myopia Control. And the first speaker will be Dr. Renan Ferreira Oliveira from Brazil, who will speak on SUL Stellest lenses, latest clinical evidence. Then I have the pleasure to speak on the European experience with the red light therapy. Then Professor Carla Lanka from Portugal will speak on atropine in myopia control. And then another speaker from Poland, Dr. Joanna Przeździecka-Dołyk from Wrocław Medical University, will speak on protocol for introducing combined therapy for myopia control using optical and pharmacological methods. Then we have a discussion, and at the end of after this session, we have the 15 minutes break. So let's start the presentation now, please.
Well, hello again, everybody. It's my pleasure now to give a short introduction to the talk on the Stellest spectacle lenses. And I want to begin by talking about how we can evaluate efficacy in myopia clinical trials. Before I begin, these are my disclosures. So last year, my colleagues and I wrote a paper detailing some of the challenges associated with conducting myopia clinical trials. Among them were the ethics of withholding treatment. We also proposed a set of solutions that are listed here. And I want to focus on a couple of these. One is using a virtual control group accounting for age and ethnicity. The second is to use short-term control data from a cohort and extrapolate those using a proportional annual reduction. So these two options are really based on this model of axial elongation that we have been working on. It was presented a couple of years ago at the ARVO meeting. The model is based on a large systematic search that ultimately results in 86 papers from 76 studies. These are some of the basic characteristics of those studies, but you can see it involves almost 7,000 participants and mostly data from randomized clinical trials. This is the result of the model. On the left, you can see the results from myopic Asian children, that is from Southeast and East Asia. And on the right, the corresponding plots for non-Asian children. In both cases, there's about a 15% slowing per year, but the myopic Asian children elongate at about 40% faster rate than their non-Asian counterparts. So these data could, in theory, be used to create a virtual control group, or that 15% slowing could be used to extrapolate over time. But I want to focus first of all on this idea of a virtual control group. So let's go back to these models again, and first of all, focus on the data from the non-Asian children. I've highlighted a number of the studies that perhaps you may identify or may recognize from this data set. You can see that a number of studies from the US, the Blink study, the Achieve study, the CHAMP study, and also the study by Chamberlain, the MySight clinical trial, they all show very similar data, but there are outliers. So if we go now to look at the Asian children, I'm going to again colorize a few data sets. The one down the bottom there is perhaps one you're familiar with. That is data from the ATOM study. And you can see that even though these are Chinese Singaporean children, their rate of elongation is far slower than anything else that's been reported in the literature. And that's very curious. The other three studies that I've highlighted are three studies all from Hong Kong, all from the same institution that in turn evaluated progressive addition lenses, spectacles, and contact lenses. And again, you can see, even though these are all presumably from the same population of Chinese children in Hong Kong, there's a great deal of variation in those children. So I think this identifies a problem in using these data to create a virtual control group. So we have called on this proposal, and we don't really encourage that unless it's really a last resort from, say, a practice-based population. Now, we do think it's appropriate to use short-term data and extrapolate those. So we first published on this when we took a look at the LAMP study, which looked at long-term slowing of axial elongation and myopia progression using various concentrations of atropine. And in the original study, there were only control data for 1 year. But we extrapolated those using a 15% slowing rate, and we're able to estimate what we believe is a pretty good estimate of the long-term or the 3-year efficacy for different concentrations of atropine. This approach was also used recently in the evaluation of the dual focus contact lens. Here, the researchers had 3 years of control data, but then after 3 years, all of the subjects were fit or continued in the dual focus contact lens. But again, the authors were able to extrapolate the 3-year data and come up with an estimate for the 6-year efficacy. So I thank you for your attention. I'm going to pass it over to my colleague now. But most of the papers I've talked about can be accessed through these QR codes, or I'm easy to find. Thank you.
Hello everyone, my name is Renan Oliveira. I'm an ophthalmologist and head of medical affairs at EssilorLuxottica Brazil. Thank you for the opportunity. It is a pleasure and honor to participate in this international event with such important topic, the control of myopia progression. In this presentation, we will understand the technology of the Essilor-Stellest lens and go through some of the main publications with the clinical evidence of its efficacy and performance. This document contains information on assets owned by Essilor. In addition, this material is of educational nature only and cannot be used for marketing or promotional claims or purposes. The Essilor-Stellest lenses provide myopia correction through a single vision zone and myopia progression control provided by the highly aspherical lenslet zone. It comprises 1,021 contiguous lenslets organized in 11 rings. Each lenslet is of aspherical geometry. The lenslet in each ring have the same optical design, and the lenslets in the different rings have different optical designs computed according to several geometric and optical parameters, resulting in a volume of slowed down signal in front of the retina and following its shape. The lenslets cover 40% of the lens surface, resulting in a myopia control progression function in all gaze directions. This presentation encapsulates a summary of the Essilor-Stellest lens 2-year clinical trial results, followed by the 3-year results and the 4 and 5 years follow-up clinical trial results. I will also present 2 other research publications, one study aiming to assess if the use of Essilor-Stellest lens has a rebound effect when stopped, and another independent real-world study comparing different spectacle lenses technologies. We will finish with a quick overview of our participation at the 2024 ARVO annual meeting. So let's start with the 2- and 3-year clinical trial results. The controlled prospective randomized clinical trial started in 2018. Children with ages 8 to 13 years were randomized to wear either Essilor-Stellest lenses or single vision lenses, which was the control group. A recap of the 2-year results can be seen here on the right-hand side. Over 2 years, the study demonstrated that when compared to single vision lenses, Essilor-Stellest lenses slowed myopia progression by 0.80 diopters and axial elongation by 0.35 mm on average for all subjects. Furthermore, the results demonstrated that wearing Stellest lenses 12 hours per day or more every day increased this efficacy to 0.99 diopters or 67% in spherical equivalent and to 0.41 mm or 60% in axial elongation on average. Essilor-Stellest lenses were found to be comparable to single vision lenses in terms of adaptation and wearing time. In the clinical trial, 90% of children were fully adapted within 3 days, and all children were adapted to the lenses in less than a week, and were wearing them for more than 13 hours per day on average. 94% of children reported feeling comfortable with Essilor-Stellest lenses. What's more, a very recent publication in OPO journal has shown that after the first and second year, the eye growth of 9 out of 10 children wearing Essilor-Stellest lenses full-time was similar or slower than non-myopic children. You can find more details on the protocol and results of this clinical trial in the 2 articles that our R&D team has published in the British Journal of Ophthalmology and in JAMA Ophthalmology. Here you can also see the citation of the OPO article I just mentioned. The clinical trial was then extended to 3 years. In doing so, we faced a common ethical concern in this topic. With the demonstrated efficacy of Stellest lenses, would it still be ethical to keep our control group on single vision lenses for 3 years? It was decided that it was unethical, and therefore all children wearing single vision lenses were switched to wearing Essilor-Stellest lenses during the 3rd year. The objectives for the 3rd year were to establish if Essilor-Stellest lenses would still be efficacious over a longer period, and what would this efficacy be compared to single vision lenses. As we had decided to switch the original control group to Essilor-Stellest, we recruited 56 new children to form a new control group in single vision lenses. These were matched with the previous control group at the 2-year visit, and this was done to extend the progression of the main outcomes beyond 2 years. We also wanted to investigate if Essilor-Stellest lenses were able to slow myopia progression in older children. The former control group, which was switched from single vision to Essilor-Stellest lenses, compared to the new control group, would be able to answer this question, as these participants were now aged 10 to 15 years old. We will now look at the 3-year results. Let's look at the graphic on the left. The green line shows the 2-year myopia progression with Stellest lenses, and the bottom black line represents the control group. The gray line, which continues the black line, represents the new control group paired with the previous one. As the former and new control groups were perfectly matched, the whole bottom line represents the cumulative 3-year myopia progression with single vision lenses, which was 2.02 diopters. By looking at the annual progression in single vision lenses, it is clear that myopia progression slows naturally with age, from 0.82 diopters in the first year to 0.56 diopter in the third year. However, it does not stabilize, and for children between 10 and 15 years, the average progression remains more than half a diopter per year, which justifies the start of treatment with myopia control. Let's now look at the myopia progression between groups. The green line represents the 3-year progression in spherical equivalent of children wearing Essilor-Stellest lenses since the beginning of the clinical trial. The total decrease in myopia progression was 1.06 diopter over 3 years, compared to the combined control groups. This is in a myopia control range, which is of great clinical significance, as in a publication by Bullimore and Brennan, it was demonstrated that slowing myopia progression by 1 diopter should reduce the likelihood of a patient developing myopic maculopathy by 40%. Accordingly, there was a cumulative decrease of 0.49 mm in axial elongation after 3 years of using Essilor-Stellest lens compared to the combined control groups. Let's now have a look at the myopia progression of the former control group, which was switched to Essilor-Stellest lenses after 2 years of wearing single vision lenses. This is represented by the green line extending the black line on the graphic. It is important to remember that those children are now 2 years older than at the baseline, with ages now between 10 and 15. Children switching from single vision lenses to Essilor-Stellest lenses progressed 0.23 diopters and 0.14 mm less than the new control group over this 12-month period. This shows that Essilor-Stellest remains effective in slowing myopia progression even in older children. Let's now analyze the 4 and 5-year clinical trial results. Here we see the study extension from 2 to 3 years as previously described, and then continuing from year 3 onto years 4 and 5 of the clinical trial. 44 of 51 children who wore Essilor-Stellest lenses continuously for 3 years accepted to be followed for 2 more years. 43 children completed the 4th year and the 5th year follow-up. Years 4 and 5 of the clinical trial did not have a control group. This was for ethical reasons, as the new single vision lens group recruited for the 3rd year were given a pair of Essilor-Stellest lenses at the end of year 3. Instead, an extrapolated control group was used for years 4 and 5 based on a model proposed by Champ and collaborators in which mean axial elongation decreases as age increases by 15% per year, and a model proposed by Smotherman and collaborators in which spherical equivalent decreases by 9.7% per year on average. These models were applied to the initial control group that participated in the 2-year randomized clinical trial. An average decrease of change in axial elongation by 15% per year and an average decrease in spherical equivalent by 9.7% per year was applied to the single vision lens group data from the first 2 years of the clinical trial. The accuracy of the extrapolated control group was assessed by comparison to the single vision lens group that were matched to the initial control group at the end of year 2. It was found that myopia progression and axial elongation in the extrapolated control group was very comparable to the actual change of axial length and spherical equivalent during the 3rd year with these real-life recruited age-matched controls. Therefore, Champ and Smotherman models were validated by comparing against the year 3 single vision control group. These models proposed by Champ and Smotherman and their collaborators could be valid options for avoiding placebo control groups if prior change in axial length and spherical equivalent are available. The 43 children who completed the 5th year follow-up were now aged 13 to 18 years. In the 4th and 5th year, there was a slower change in spherical equivalent refraction with Essilor Stellis lenses compared to the extrapolated control group. Over 5 years, Essilor Stellis lenses slowed myopia progression by 1.75 diopters on average for all subjects compared to the extrapolated control group. This shows that efficacy was sustained over a 5-year period. Accordingly, Essilor Stellis lenses slowed axial elongation by 0.72 mm on average for all subjects compared to the extrapolated control group, showing a sustained efficacy in controlling axial elongation over a 5-year period. From the results, we can see children wearing Essilor Stellis lenses for 5 years show mean progression of 1.27 diopters and mean axial elongation of 0.67 millimeters. Another way to interpret these results is to consider how long it took the untreated control group to progress by these same amounts. The answer is less than 2 years. Therefore, it can be stated that Essilor Stellis lenses saved over 3 years of myopia progression and axial elongation. An advantage of this analysis is that it uses the 2-year control data from the original randomized clinical trial lens and does not rely on control group projections or interpolation. To conclude, this study shows that Essilor Stellis lenses remained efficacious over a 5-year period, with a total slowdown in myopia progression by 1.75 diopters and axial elongation by 0.72 millimeters on average over 5 years. Furthermore, the Essilor Stellis lenses remained effective in slowing myopia progression in older children up to 18 years old. Here you can see the references for the previous slides. So the 3-year results were published in the American Journal of Ophthalmology in 2023, and the 4- and 5-year results were presented at the 2023 and 2024 ARVO annual meetings. I will now present the results of a 2023 publication in the American Journal of Ophthalmology. This was a crossover trial. It was also randomized and double-masked, in which 119 Vietnamese children aged 7 to 13 years were randomized to wear either Essilor Stellis lenses or single-vision lenses. After 6 months, they crossed over, so the Essilor Stellis lens group were now wearing single-vision lenses for the next 6 months, and therefore any rebound effects could be measured. Children were compliant with lens wear. An average of 14 hours per day of lens wear was reported with both lenses. The data were not suggestive of rebound when patients were switched from Essilor Stellis lenses to single-vision lenses. The efficacy comparisons also confirmed that Essilor Stellis lenses slowed myopia progression compared to single-vision lenses. This article results have clinical significance, since the rebound effect is important to note for any myopia management treatment. And finally, I'll present an independent research publication in Scientific Reports in 2023. Scientific Reports is a peer-reviewed, open-access scientific journal by Nature.com. This independent, real-world study was carried out in China. It was a retrospective analysis of data from children who were prescribed with Essilor Stellis lenses or DIMS spectacle lenses in Guangzhou Higher Eye Hospital in China. It is the first independent study to compare different spectacle lenses technologies for myopia control. As you can see on the right side, the article's key results and conclusions show slower myopia progression and axial elongation in the highly aspherical lenslet group, that is, with Essilor Stellis lenses. As an independent, real-world retrospective study, it is important to note some study limitations. Some confounders could not be identified in the study, such as time spent outdoors, near work time, parental myopia, and duration of spectacle lens wear. Also, average follow-up was approximately 9 months, and 1-year outcomes are predicted based on a standardized method, which might be slightly different from the actual results at 1 year. Also, some children's cycloplegic refraction was not measured in the follow-up tests, and results may overestimate myopia progression. And lastly, data were from Chinese children in only one region. We are proud to announce we've had an important participation at the ARVO 2024 meeting in Seattle with the presentation of these 5 scientific posters. In one of them, it was assessed the influence of first-time correction on myopia progression and axial elongation in myopic children by comparing highly spherical lenslets and single-vision lenses. The study concluded that for myopic children, myopia-controlled spectacle lenses with aspherical lenslets should be prescribed as a child's first pair rather than single-vision spectacle lenses. Another poster showed highly aspherical lenslets were effective in slowing down both central and peripheral eye elongation in Chinese children, with greater effectiveness in the central and paramacular region. Another poster showed that wearing highly aspherical lenslets for 2 years had no significant impact on cylinder power and corneal astigmatism compared to single vision lenses. And finally, another poster presented by an Italian group assessed the efficacy of highly spherical lenslet technology combined with low-dose 0.01% atropine eye drops to slow myopia progression. They concluded that both treatments alone were efficacious in slowing myopia progression, but by combining treatment with Hall and atropine 0.01% seemed to be more efficacious in slowing myopia progression in terms of spherical equivalent than single treatments. However, regarding axial elongation, the combined treatment resulted more successful only compared with 0.01% atropine eye drops. Finally, we are also pleased to announce we have an ongoing Essilor lens European clinical study. In March 2024, we launched this multi-center prospective interventional 2-year study with Essilor in European children aged between 6 and 16 years old at the time of inclusion. The 3 investigator centers are Hôpital Fondation Rothschild in Paris, Center for Eye Research in Ireland, Dublin, and Erasmus University Medical Center in Rotterdam. Thank you very much for your attention.
Dear colleagues, it is my great pleasure to speak about the European experience with red light therapy. Well, as I mentioned, we have a very interesting group, European Network for Myopia Prevention and Control. Here are my financial disclosures. Some might be relevant to the topic of this presentation. Let me start with the showing the graph from one of our epidemiology papers. Well, just to partly repeat what already mentioned about the prevalence of myopia worldwide. Already well known that the highest is in the Southeast Asian countries. Then, as we can see in the middle of this graph, we have North America and Europe with a prevalence around between 40 to 50%, according to at least to some studies. Also some controversies about this topic exist. This led, as you see, to the headings of some European magazines, where you can see them, Financial Times, Guardian, Independent, saying that short-sightedness on the rise across Europe. And this is based on the results from the European Eye Epidemiology Consortium that was published already nearly 10 years ago in the European Journal of Epidemiology. And this shown that the prevalence of myopia among young adults in the age of 25, 29-year-old was between 45 to 50%. Well, there are some other data showing that there is an increase of increasing trend of myopia in Europe. This is the data from UK, from NICER study, as you see, that was conducted in the years 2006, 2008. And when compared, for example, to much older studies by Soulsby from the 60s, they noted a twofold increase in the proportion of myopia in the UK over the last 5 decades. What about Poland? Unfortunately, we do not have a lot of epidemiological studies. I will show what do we have. On the left side, we have the data from the study by Dr. Dals, and she found in 2003 the prevalence of myopia in the 8-year-old children of 2%, and then Cepita versus Cepita et al. In 2007, in the same age population, found it in already 8%. And then we have the recent last year study that for the same 8-year-old children found already nearly 17%. So based on this however limited, but available data, we see the clear increase in the prevalence of myopia in Poland. So that was already nicely presented by Professor Barrymore, and finally it is difficult to add anything general to his great presentation. What do we have in myopia control in Europe? Pharmacology, atropine in different concentration, different optical methods, ortho-K, soft contact lenses, eyeglasses, mostly of course DIMS and Halls, and low intensity red light therapy. None of these available methods, however, is not perfect, as we know. This is the graph from one of our studies with Professor Karla Lanka, in which we compared the efficacy of different presently available methods, and what we can see that they are comparable when we compare ortho-K lenses to atropine 0.05%, then dim spectacles and Hall spectacles or MiSight contact lenses. Their effectiveness is very similar. Last year, there was a very, at least big and quite interesting paper published on this topic as a Cochrane database systemic review. As you see, intervention for myopia control in children, and this contained over 260 pages, so huge analysis. Just to show you one table from this paper, this is the change in axial length at 2 years. This is probably most important for us, and certainty of evidence for a majority of the analyzed technologies. It was low, sometimes very low, and moderate with the contact lenses, ortho-K, and atropine. And this analysis, red light therapy was not included. So yeah, this is the new approach that was introduced just a few years ago, and came from China, as you can see it here. So majority of studies and the idea is brought from China. We have a different device models available in China. In Europe, the only one device that is, I will show it later, available is a bit different. So this is the home treatment based on the pattern 3-2-5. So 3 minutes treatment twice per day at home for 5 days a week. And this is based, as you can see here, on several strong methodological studies. Two, as you see at the bottom, published in ophthalmology journal, randomized control trials. And here I will present shortly the results of these trials here. So they shown up to over 87% of myopia control efficacy. They found that the higher the patient compliance was, the higher the device myopia control efficacy. they achieved, as I mentioned, over 87% of myopia control efficacy when patient has over 75% compliance. And the clinical overall treatment efficacy was over 76%. These studies shown 24-month long-term efficacy and safety profile of this therapy. There were no functional and structural damages or side effects observed. 75% myopia control efficacy over 2 years, and also found that red light therapy treatment had a sustained effect on myopia progression after withdrawal of this therapy for 12 months. Yes, here we see the device that is registered, that's a CE marked in Europe, so it's registered for clinical use. And at first, to share my personal experience is to say that it's very easy in a demonstration in a clinic to parent and the child, certainly easier than atropine or contact lenses, but probably more difficult than spectacles. Then it is also best fitted, for example, instead of atropine in slowly progressing myopes. It can be used as an adjunct, and as a matter of fact, it is well used more and more often as an adjunct to DIMS or holes in quickly progressing myopes. This is also the only therapy available for children younger than 6 years old in Europe. And because some of the therapies are limited by the size of myopia, like DIMS, they according to the license, they cannot be used in myopia higher than -6 diopters. This therapy also could be used for in high myopes. There is an increasing number of papers in the literature. Here you can see I found 55 papers, recent papers on this topic. Just shortly to discuss some of them. Here you can see on the left side the paper that was published 2 years ago, and shown that this, of course, therapy of 650 nanometers significantly slowed down the myopia progression in children aged 6 to 12 years, with no observable side effects in the short term. And the second paper on the right side, they found that the, again, use of this therapy might have a strong effect for myopia prevention in children. So reduce the risk of myopia onset without risk of adverse events. Here's the most recent paper, just published at the end of April this year in JAMA Ophthalmology, and they shown that the use of this approach led to the myopia reduction by nearly 70%. We started in recent months a prospective study, as you see, a multi-center, single-arm prospective study on the repeated low-level light for myopia progression. Well, in Europe, as you see, I am the, let's say, one of the principal investigators, and we conduct this study together with the professors from France, from Norway, Portugal, Spain, and Germany. I will shortly present the background of this and basics of this study. So this study will enroll myopic children aged 8 to 13 years old as subjects. Of course, all centers will be provided with the same red light therapy device, and each center will have professionals available to provide guidance to the participating children on the proper use of this device. Eligible subjects will receive treatment every day, with each treatment lasting for 3 minutes twice a day with a minimal interval of 4 hours. And the study will evaluate the incidence rate of full myopia control that we defined as an axial elongation of less than 0.1 millimeter at 12 months after red light therapy in myopic children, change in axial length, cycloplegic spherical equivalent change, best corrected visual acuity of subjects at 4 months, 8 months, and 12 months after enrollment. Here you can see the flow chart for the subject recruitment and the follow-up. Yeah, so the hypothesis is that the red light therapy is able to achieve full myopia control effect in the proportion of more than 30% in European myopic children at 12 months. And the primary objective is to assess the incidence rate of axial length elongation of less than 0.1 millimeter in myopia control at 12 months. We have also secondary objectives to assess the change of axial length after red light therapy, to assess the change of cycloplegic spherical equivalent refraction after red light therapy, and of course, to assess the safety of red light therapy. Yes, here we have the summary of the primary and secondary outcomes. And I have opportunity to use this therapy in 10 patients. Here you see some data from these patients. They all of them completed, I would say, 6, even 8 months. After 8 months, and the major advantage is that well, we as doctors can follow the compliance because we can see if the device was used or not. So we can see the compliance for each of these children. This is the, let's say, the column, well, under the word compliance. So we can see that the first, for example, use it for 99%, the second 67%, and so on. So we can really analyze the results in the perspective of the real use of the device. This is very important, at least for me. So in conclusions, the present methods of myopia control are not perfect. Combination therapy might be the future. It brings more effects than each therapy alone, and 650 nanometers red light can effectively delay the progression of myopia in children in different age. And at the end, I would like to welcome and invite you, everybody, to join our European network for myopia prevention and control. And I would like also to invite you to join our it's European AVO. It's the European Association for Eye and Vision Research. I am the present president of this society, and would like to invite everybody to come to Valencia. We will have a few myopia sessions at this meeting, presenting very interesting data and original studies. Thank you very much for your kind attention.
Good afternoon, everyone that is attending this online conference dedicated to the topic of Myopia 2020-2024. It is my pleasure to be here today presenting on atropine and myopia control. And before I start my presentation, I would like to thank the invitation to be present here. So I'm speaking today from Abu Dhabi, the UAE, where we are bracing for sunny and hot summer. And today I'm going to talk about low-dose atropine. And I will try to answer this question during my presentation. Is low-dose atropine a proven treatment to reduce progression of myopia? So let's see what has been published so far and what we know so far, and also identify all the questions we have regarding this treatment. So for the past few years, we have a lot of research supporting the use of low-dose atropine. So there were several publications, mainly several randomized control clinical trials. And those clinical trials include landmark studies. Some of the landmark studies are the atropine for the treatment of myopia, the ATOM studies, and the low concentration atropine for myopia progression, the LAMP studies. But there is also in the literature a lot of systematic reviews and meta-analysis that support the use of low-dose atropine. The supporting points out that they are safe and effective. However, when looking at the efficacy, we have data that support short-term efficacy, and we need more studies to look into long-term efficacy. So let's start by the beginning. In this graph, I'm showing the results of the ATOM from Singapore, one of the first studies showing that low-dose atropine was effective in arresting myopia progression. Here in the graph, we can see a comparison of a placebo group with other groups using different concentrations of atropine. And as we can see from the graph, the 0.01% atropine were considered the most effective at the time. Here, another graph from ATOM study showing the results for about 5 years of treatment. And we can see from the graphs and the information in the paper that about 50% of myopia progression was arrested during these 5 years. Nevertheless, after publication, there were several analyses of the data. And although we found that spherical equivalent was reduced, there was some doubts regarding actual length progression. So as you can see, the data was reported in this graph, especially the data on AL progression. The graph shows the data from the placebo and atropine groups from ATOM study, but also the data from the LAMP studies from the 12 months and 24 months. So as we can see from the graphs and looking at both papers, it seems that although atropines 0.1%, they control the spherical equivalent, they were not so effective in controlling AL progression. And there was a lot of discussion and comments and regarding the type of concentration we should use. Another study that was published is the atropine for the treatment of childhood myopia in India. This was a randomized controlled trial that again supported the use of 0.01% atropine in reducing spherical equivalent progression. But again, when looking at AL, they did not find significant results. There were many studies published in Asian populations. And of course, we would like to also know the results from non-Asian population. And the last few, two to 3 years were very important, as we now have data, more data than before. So let's look at the results from this study published almost 1 year ago. This is the data from the CHAMP, where the authors looked into and included data from USA and Europe. And they look into two types of concentration, 0.01% and 0.02%. The authors found that 0.02% were not effective, but suggested that 0.01% were in fact effective. Looking at the results, there was also some discussion about what the authors found, and also regarding what we should look into, what is a clinical meaningful result. But there were more studies published on other populations. So this is a graph, the results from the Western Australian ATOM study published in 2022. So as you can see, the results show that atropine was safe and effective. Nevertheless, when we look at the results from the 18 months to the 24 months, you can see that there seems to be a decrease in the efficacy, which the authors concluded that maybe it was related with a dropout in some of the children in the placebo group. Nevertheless, we can see the decrease here in the graph. Another very important study that was published was the Mosaic. This is the myopia outcome study of atropine in children, which included mainly white European children. And the authors look at the 0.01% concentration. So as you can see here, although the results were effective, we can see that they were not so effective as we may expect regarding atropine efficacy. And we were puzzled with the results from the PEDIC study. As you can see here in the graph, this was published at JAMA Ophthalmology, the results from the 2-year clinical trial in the USA. And you can see that there were no significant differences between the treated groups with atropine 0.01% and the placebo groups. Again, the community was puzzled with the results, and there were several theories that have emerged to try to explain what happened and why the authors did not find differences. So there are several indications of what can be the hypothesis. One of them was the race. There's also differences in age range, but also iris color, and there was some discussions about inconsistencies in the formulation of atropine, which can lead to differences in bioavailability and effectiveness. We will look into all of these details later on my presentation. But now let's look a bit into concentration. So here in this graph, I show you the results from the 3-year LAMP study. As you can see from the lines, we can see that those results support the use of 0.05%. So as the best results in terms of controlling myopia progression, but also AL. This is data from the 3-year study, and the LAMP now has data from 5 years as well, as I will show you later. But it's not only concentration that is important. We also have to look into age, as we know that age has been described as affecting the results. And here we can see from the Lee et al. Study where the authors plot age and concentrations for spherical equivalent progression and AL progression. And as we can see, higher concentrations of atropine may be necessary to control SE and AL for younger children when we compare to older children. And the reason is that older children, they have a natural decline of progression. There has been many discussions also regarding ethnicity. Today, I bring you this systematic review that was published in 2014. At the time, the authors concluded that in Caucasian children, the effectiveness of the treatment with atropine was lower compared with Asian children. Nevertheless, we must take in consideration that the study was published many years ago, and there was not much studies using low-dose atropine at the time. So now we are looking into those details with the new studies. So one of the studies that our team has published is this one. We were looking into atropine efficacy, but most important, we wanted to look at data from non-Asian regions, and especially trying to understand how is the effectiveness in Europe populations. So we found that 0.01% compared to 0.5% was effective in non-Asian regions. Nevertheless, there was some limitations of our study at the time that I want to point out. We found that there was a lack of prospective and randomized controlled trials in non-Asian populations. From the 9 studies that we included, only 3 were RCTs. We also found, when we were looking and analyzing the sample included in the studies, that many had mixed ethnicities. And this included studies performed in the USA, Australia, and some European countries. We are now looking into the data that we have so far, and I'm showing here some forest plots of unpublished data that we are looking for with our collaborators in the Aston University. And as you can see, when we plotted all the studies and with different concentrations, and we divided into 2 groups, Asian and non-Asian, we can see similar results as the previous systematic review. So it seems when looking at the results, it seems that in fact, the effectiveness of treatment seems to be less in non-Asian ethnicities. Let's see what we found more. As most of the studies in non-Asian ethnicities are published with 0.01% atropine, we reduced the list to just those. And as you can see again, the efficacy seems to be reduced in the non-Asian. And now when we compare the 2 groups again, the difference is not significant anymore. So this is unpublished data, and we are still looking into other factors as well. And we will hope to have more data to show you in future. So let's see other important characteristics of atropine treatment, like atropine formulation. And I bring you this publication, which is published by Catherine and her team, where the authors look at that compound 0.01% atropine and to understand what was inside the bottle. And interesting, they found that there were differences in several characteristics, such as the pH, but also viscosity, among other factors. And I've plotted some of the data in this graph, as you can see on your left, and it's puzzling to see that even storage recommendations were different for different bottles. So this is an important topic that we should look out for. And last year, the end of the year, there was this perspective published in Acta Ophthalmologica, exactly pointing out this problem, that there are some studies where atropine drops were found to be ineffective, or the clinical effect was small, and some of those studies use the same type of atropine formulation. So this is more that we need to do look into those details. How about treatment duration? There has been a lot of discussion about treatment duration. I don't think we have the answers right now, but we had this study from the Atlas in Singapore that puzzled our community when the authors reported that when they look into people that had been treated in childhood for 2 to 4 years with atropine, they have looked into the results 10 to 20 years after treatment. And they found one thing that is very important, is that the treatment is safe. Regarding effectiveness, they did not find significant difference between the placebo and the intervention groups. So what does it mean for us? Probably it means that the treatment needs to have a higher duration. How much higher should be, we don't know yet, so we need more studies. But perhaps this is a bit concordant with already many clinicians are doing in clinical practice when they tend to stop treatment just towards the teenage year, where also the risk of rebound effect seems lower. So our group is very interested in looking into rebound phenomenon, and we have plotted this data from the LAMP studies, and we were really interested in looking at the rebound for different concentrations, but also looking into age groups. So as you can see from the graphs, it seems that the rebound is related with concentration. So higher concentrations seems to lead to higher rebound, but also it's related with age. As you can see here, it's much lower when we look into all the groups. So this may have implications for clinical practice, probably because the tempering of treatment may be more important for higher concentrations and younger children. We have now also data from the 5-year clinical trial, the LAMP study. And from this study, we now know that many children had to restart their treatment. And this may mean that, in fact, when we have an abrupt alto cessation of the treatment, higher rebound is expected. So tempering may be a very important strategy. And in clinical practice, many of our clinicians already temper the treatment for 3 to 6 months, but we don't really know how tempering schedule affects the results. For example, we think that maybe in teenagers that are age 14 to 16 years, maybe we don't need to use this tempering schedule if the studies confirm that the rebound is small or clinical insignificant. However, at this point, we don't have studies to support this hypothesis. I'm almost coming to an end of my presentation, and I would like to speak a bit of combined therapies. So there were a lot of research on atropine combined with orthokeratology. And although the research supports that combining therapies is more effective than monotherapies, the results are most effective for the first 6 months of treatment. We are now seeing more studies coming and being published with other options, such as atropine in DIMS. As you can see here, the study by Nucci et al., where they found that combining atropine with DIMS is more effective than monotherapy alone. But on the contrary, there is a recent study that looked into combination of atropine with contact lenses to control myopia progression. And the authors found that the combination therapy did not present an advantage over monotherapy. I will not continue to speak about this topic as I think we have a presentation later on this panel. So coming to the end of my presentations, we now know that we have more questions than answers. So what to do with these? Some take-home messages for us to think. So although we have questions regarding atropine concentration, treatment protocols, we now know that they are safe and they can be used. And as we know, myopia has been an evolving field with a lot of new research coming out, and we still need more research to confirm some of the treatment options. First, we need to confirm if long treatment is effective. We also need to understand more on the value of combined therapies, but also duration of the treatment. How effective are tempering schedules to avoid or reduce the rebound phenomenon, and what should be the age of treatment cessation. Thank you very much for your attention.
Hello, my name is Joanna Dołek, and today I wanted to introduce you to a protocol for conducting combined therapy of myopia using optical and pharmacological methods. Medical decision making is difficult. It should be based mainly on evidence-based medicine, while taking into account, of course, the opportunities and risks associated with the use of a particular method. We should use available resources that are independent of companies, among other sponsoring companies. We should also rely on the availability of a given information and leave it up to the patient to choose the given correction method. Each time, then there is a place for us as a person who informs, who educates, but on the other hand, we should not make the decision for the patient. They need to take the decision themselves, and remember that we always match the correction to the patient, not vice versa. The current therapeutic options are very wide. Among others, we have pharmacology, we have spectacle correction, we have contact lenses, we have visual rehabilitation, or the so-called behavioral or vision rehabilitation, depending on different places in the world. This can be called or organized differently. So don't be surprised, for example, there is a difference between Polish visual rehabilitation and visual rehabilitation conducted in the States. There are different possibilities for the patient, different organizational possibilities of the system. Culturally, we are also different, so these will not be the same therapies. And then we also have combined therapies when we use one or more of the previously mentioned methods. The practical considerations for the process of managing a patient with myopia are based on 4 different factors. First, are patient-dependent factors, so those where the patient can express their opinion, which directly depends on their opinion. They can talk about the preferred method of correction. We can have a subjective or objective refraction test, because there is also a very big, a lot depends on the patient, if they will cooperate or not. And then there is the condition of binocular vision. And this condition and guiding the patient in terms of the state of binocular vision is very important in managing myopic patients in general. The second group of factors is independent of the patient, and here we can say about morphology or the structure of the eyeball, as well as objective tests, so that those that we can see in front of us. We are also obliged to inform the patient about complications and myopia related risks, both near and distant risks. On the basis of the risk analysis, we will plan various measures, and on the basis of the near and distant risk analysis, we will also make our medical decisions. And then the last factor, very important for the patient, but for us is the last factor, is the cost of therapy. Because, of course, we should also always think about the cost of therapy at the very end, because the welfare of the patient and the risk analysis of possible side effects or complications of the process itself are more important. The cost of therapy is very important, and because of that, it's never zero for the patient. So, especially the myopic patient, we have to talk about the cost of therapy quite extensively with the patient, and we should also give the patient some sort of price range. Or leave it up to the patient not to decide when they are in our office, the moment after we give them the options. Then binocular vision versus short-sightedness or myopia. Unfortunately, not every method of therapy or not every method of correction will have the same effect on binocular vision. Studies have shown much information about atropine, that atropine lowers the amplitude of accommodation. However, I don't see that in my office. On the other hand, there have been such publications and reports. Nevertheless, they may lead to exophoria, for example. I have seen such patients too. Therefore, I don't recommend these lenses to myopic children, only in selected, very highly selected situations. However, contact lenses for inhibiting the progression of myopia or spectacle lenses for inhibiting that progression, depending on the design, are already quite numerous on the market. And we must realize that they will differ. They will have, for example, the possibility of increased or decreased myopic channel. This effect, in the case of contact lenses, will be debatable in the case of accommodation efficiency, whether this will be disturbed or not. So it's still being studied. And then in ortho K, we have higher exophoria, and we use greater exophoria than in soft contact lenses. On the other hand, if we have exophoria and we use eyeglasses for myopia progression control, then spectacles will improve our slight exophoria to far. And again, in scientific studies, we don't have such reports yet, and I have observed it already in my office, that patients with slight exophoria too far have an optical zone, and they have to aim with this optical zone to see well, so that they don't hit the zone of defocus in far vision. So they deal better with exophoria. It's worth remembering. It's worth keeping that in mind. And then, what does the basic control scheme look like? It's based on the so-called qualifying visits, and I feel this is one of the most important visits because it's usually combined with an optometric examination. At least it's in our center. It's not possible to have this visit without such examination, and later in the control scheme up to a year. And I believe this is the best scheme because we have the whole picture of the patient. And then as for the family history, we always evaluate the risk of eye diseases, but also the risk of, let's say, genetic load and hereditary load in the family. Because often whole myopic families come to us and they have their history, their experiences, their difficulties. Sometimes even complications in grandparents may depend on what decisions parents make for their children. So it's very important. So we have a diagnosis of myopia at the time, we do the test, and then later, usually either at the time of the qualifying visit, or if we don't have the ability to do everything on site, we send the patient for additional diagnostic tests. Such tests would be mainly actual length of the eyeball. Sometimes it's topography. In most cases, patients who have keratometry done, well, in our center, both central and peripheral keratometry is done as standard. Not everyone is qualified for topography. It depends on the keratometry parameters. On the other hand, in places where I don't have peripheral keratometry or no keratometry at all, I prefer to see axial length together with topography every time during the first visit. It's just safer. Then diagnostic and additional tests. Let's divide them, since some examinations will be done by me, the ophthalmologist, and some additional examinations, some will include additional examinations, and some will be done by the optometrist. Certainly, corneal topography and axial length will be commissioned, then refraction after accommodative paralysis. Every time I put on the glasses I want to fit to these patients and check how they see with dilated pupil. I'm checking if this vision is different with dilated and narrow pupil, and would the visual acuity change, or would it be analogous to VA before paralyzed accommodation? And then refraction before that, or the examination of binocular vision, is usually performed by an optometrist. So how will this examination of binocular vision look like? Here there's a diagram, and now let's talk a bit about what should be very important here. I would say binocular balance is very important here. Failure to perform that can mess up our results. Not only will we not quite know if everything is okay, but with unbalanced situation, we will have a situation where accommodation will push one eye into progression. This sometimes happens, that accommodations that are unbalanced in one eye will pull the progression of both eyes. Then the standard test to check for overt or covert strabismus. The 4BO is the central fixation test here. It is generally used to verify that there are no microsclerosis, that the eye alignment is correct, there are no retinal problems. Then we have the Worth test for distance and for near, using a flashlight. This is done by the optometrist next door. So all these tests, numerous tests, are done before the ophthalmologist visit. In the Worth test, we are also looking for fusion, no microsclerosis, there's nothing extra going on, no double vision, despite correct eye alignment, for example. So if a child reports any problem in the history, we often then include fusion ranges for distant and for near. We usually do them in the open using prism bars. We don't want to do it with phoropter, especially in children. Generally doing fusion ranges this way is difficult. They will always be reduced in size. In children, there is an extra piece of equipment in front of their eye, so they are afraid of it. So let's not do it. And then close-up examination. So these are standard examinations. We would like to see stereoscopy, not just if it's plus or minus, but we want to accurately assess the number of angular seconds that the child is able to distinguish close up. This is quite important in terms of verifying whether there is no anisometropia. We will want to have one eye verification, for example, using Ishihara test. Sometimes one eye sees colors better, the other one a little worse. Then we will want to diagnose additionally what the problem exactly is. Then the Maddox wing, so foria to near, including the AC/A. So if we have the Maddox wing, we have some information about the foria. We will know if it's exo or eso. Then we insert the -1 lens and read the result again, and the difference will help us to calculate the AC/A. Then the next points are visual near point and the convergence point. And the point of visual near is the point at which the eye in question will still see with focus. Sometimes it happens that we don't have an equal point of near when the eyes can still see with focus. Hence, it's useful to examine the eyes separately. First right, then left, then simultaneously, then examine the convergence point. And we do all this to find out whether the patient has anisometropia with aniseikonia. It consists of unevenly sized retinal images, and while the static form of aniseikonia is not somehow very difficult to deal with because children adapt very well to the difference in image size, it's a matter of reprogramming the brain to that difference. And here are no major problems, but we would have problems with dynamic aniseikonia. What is it? Well, static aniseikonia, such an eye will see two overlapping images on top of each other, one large and one smaller. In contrast with eye movements, the impulse to the brain is completely different. Each eye will move a little differently. So we look in one direction and one eye moves more than the other because the image is different. We look the other way and exactly the same situation for up and for down as well. Unfortunately, dynamic aniseikonia, which we often don't realize, is a much more difficult problem to deal with for a patient than with static aniseikonia, which can actually be quite adapted by children patients especially. Dynamic aniseikonia can also be dealt with. Usually it's based on contact lenses. Nevertheless, even by applying contact lenses dedicated to this correction, to the error, we will not be fully know that whether this is dynamic aniseikonia or not. Hence, it's also worth considering visual exercises and sending such a patient who has signs of aniseikonia or symptoms suggesting aniseikonia to visual rehabilitation. So, what are the symptoms of aniseikonia? If there is a little discrepancy, these symptoms will be virtually non-existent. So there will be good stereoscopic visual acuity for distance, good for near. On the other hand, the already small aniseikonia, not the big one above 5 degrees, but the small one, can give stereoscopic disorders and problems. This happens precisely because of the differences in eye movements. And while the average patient will be clinically asymptomatic, there might be some extremely sensitive patients. They may have some asthenopic symptoms, headaches, reduced fusion, different capability to the distance, or problems with judging the distance of moving objects. Only stereoscopy will give us such information. We can try summation as a function of contrast sensitivity. This will be comparable to stereoscopy for near. On the other hand, the binocular electrophysiological summation is much more sensitive. However, it's a large study, rarely performed. So let's do stereoscopy. It's a much needed parameter for us. What if we have aniseikonia? So anisometropia with aniseikonia would be an indication for correction with contact lenses. If we don't have it, still, let's continue to verify the patient whether maybe they would benefit more from contact lenses. If there is aniseikonia, contact lenses will simply be a better choice in general. And if there is no aniseikonia, there are additional factors that will make us want to switch to contact lenses, despite the relatively good parameters. So sharpening in topography, significant differences in axial length in relation to age and gender, and lack of full visual acuity. It's not 1.0 in glasses can be such symptoms that will suggest that the patient will benefit more from contact lenses than spectacles. Why is the axial length important? Because it will increase with age. This increase will be different in the general population and in the myopic population. And we have known that for at least a few years. We don't want to go beyond the value of 25 and 5, 26. Because above these values, and there are also publications about it, that there are possible complications or consequences of such a high value. Percentile grades will help us. We can download them quite easily from the internet. They will allow us to monitor the cases. Sometimes they are even uploaded in the devices we use, or there will be such patients' booklets that will contain percentile grades in them. And then, how would the follow-up look like? We diagnose, we chose the best option, and then what happens next? We check the patient on average every 6 months. It doesn't have to be an ophthalmologist visit every time. A visit at the optometrist's office will suffice, but in a center where an ophthalmologist visit is also possible very quickly. And it has to be an optometrist trained specifically for myopia progression, so that they can examine the eye in the slit lamp, anterior segment, posterior segment, at least with a narrow pupil. We want to evaluate if there was a previous progression above 0.75. We say that we don't want more progression than 0.5 diopters per year. We check if we have a genetic load and if the axial length is above normal age above normal for age and gender. If this is the case, we want to use combined therapy. If we had only one factor or few risk factors, probably then we would choose a single unified method, for example, optical correction or pharmacological correction. But keep in mind that the combined method, especially pharmacological with optical, gives us a better chance for the patient being stopping the lowering the progression better, having reduced progression combined to all other methods used as single ones. So we don't want to wait. We don't want to allow a situation where the patient is -5 and has a very long eyeball that will then cause later complications, such as changes in the optic nerve disc, or maybe there will be some fractures. Such patients will happen. We want to stop that progression very quickly. Let's also take into account the order of procedures. What does it mean? Well, if we choose a particular correction method, nie tylko mówię, że to ja. Why is it important? Because with contact lenses, we should still do re-examination of binocular vision. That's the first thing. And we should do it without the atropine test in well-fit lenses. The second point is that we should only add atropine when we have a stabilized condition on the eye surface. Atropine can affect some corneal parameters, such as, for example, hysteresis. We don't want to have that at the time of fitting the lenses. We want to fit the lenses first and then introduce atropine. And that would be it. Thank you very much for listening. Have a good day.
Discussion. I hope that our speakers are with us. I see Carla. Hello, Carla. Good to see you. And Dr. Oliveira is with us, and hopefully Dr. Krzysztof, but I cannot see her. Okay. Nevertheless, okay, so we wait for your questions. I mean, this is the comment to our audience who still can put the questions on the chat. We are here for you to respond to your questions. I have a question in the meantime to Dr. Oliveira. Well, you presented a lot of the studies based on the HAL technology, but as I noticed, great majority, if not all of them, were, let's say, industry sponsored. Are there any totally independent studies based on this technology? Apart from, well, I noticed there was a last maybe not a paper, maybe paper, but certainly a conference presentation from Italy, and but I'm not really sure if it was independent one just by names, because in many of your publications that you presented, this publication have the same names. We know them. I mean, because from the early beginning, the same researcher were involved in this study. So, but finally, what about totally independent publications? Are there any?
Yes, one of the presentations, one of the papers that I presented it was scientific research papers, scientific reports. It's from nature.com, and it was an independent study done in China.
You mean Guangzhou? This study in Guangzhou?
Yes, yes.
Okay. Yeah, I noticed that. Also, you mentioned about that. Okay, so this is the one study, the independent study.
Mhm.
So finally, as we see, I mean, there is some, let's say, discrepancy. I mean, there is between the industry supported and completely independent studies. So the question is, not only for you, I mean, as a doctor who collaborates with one of the major industry, let's say, players in this let's say environment, but also for others, what to do to allow or support other independent studies, because I think that we need independent studies. What do you think about that?
Yes, sure. I think that this would be great. We welcome centers to bring us this opportunity also.
I have another question, but maybe again, I noticed, and not only from your presentation, but from my previous literature analysis review, that again a great majority of the studies were conducted in Asia.
Yes.
Including this Guangzhou study, of course. I mean, so what about other, let's say, ethnicities? I would say, but that is not only a matter of ethnicity; it's also a matter of the lifestyle. As we know, different factors influence the myopia progression. So, but what about the studies in Europe, in the US? Are they? How many studies were conducted on the whole technology in these two continents, like North America and Europe?
Yeah, so there is this poster that was presented at Arvo with an Italian group. And also, as I said in my presentation, we launched in March 2024, the clinical trial, the European clinical trial with 3 important centers, research centers. So this would be, I think, the first European study, at least, that is supported by us.
Yeah, thank you. I mean, this is certainly the fulfilling of the gap. So finally, as I understand, there are besides this ARVO presentation, no studies conducted in Europe or in US so far, just to be sure.
Yeah, now that I know of, I represent also the Brazilian Medical Affairs. I don't have full visibility of all the projects that Essilor is doing. Maybe we can ask the global affairs of EssilorLuxottica regarding this subject.
Okay, thank you.
Thank you.
Carla, so what is the future of low-dose atropine? What do you think?
Yeah, that's a difficult question, as I said during my presentation, and also Mark today with his presentation. He gave us an overview of what we know so far and a lot of what we don't know. So I think we have a lot of questions to answer. But probably the future, as I said during my presentation, will be longer treatment duration in case of atropine. We need to see for the other methods to control myopia available what can be done. But for atropine, it seems that we need longer treatment periods. But there are a lot of things that we still don't know. For example, one of the things that I think it is important that many clinicians are doing is tempering the treatment. And when we look at these clinical trials, they all start by an abrupt cessation of the treatment. So I think we need more studies, research studies, to look into what clinicians are doing and what is the result. We also need to know more about the rebound phenomenon. And one of the problems with looking at the rebound phenomenon is that many of the studies lost a control group. So we are not able to do comparisons of intervention with control. So we are looking at only treatment cessation and what happens after that. And also, as Mark spoken today, there are a part of the progression that maybe it's natural progression, and we need to understand what is a natural progression and what is the rest of the result of stopping the treatment. So I think the future of atropine is still unknown, although, of course, it's a very used treatment, and we have data to support short-term efficacy. We just need to dig deeper into more results for future and what we can do better in future to treat our patients.
Thank you. And you also mentioned that there is a lack of the, let's say, fixed combination. So this is another interesting topic we are looking forward to have the. Finally, we know that there are several companies behind some already published studies prepared to introduce the fixed combination to the market. And as you nicely presented, the studies by Mark Ballymore, that the compounded, this is the timer but we need to finish soon because of the break, that the quality of the compounded pharmacy is poor, and regarding the concentration also of the atropine, but also, finally, about the other factors that might influence everything. I mean, penetration, availability. So then hopefully in the nearest future, we will have some fixed combination that could be compared in different countries and different populations, the same content of the eye drop. Thank you so much for being with us and for the great discussion. Now we have a 15 minutes break, and then we meet on the next session at 3 o'clock. Thank you. Dear colleagues, we start now the session 2. But for any reason, I cannot see the program. Yes, I see it now. New technologies in myopia control with a very interesting program. Again, the first speaker will be Dr. Joanna Przeździecka-Dołek from Wrocław Medical University with a talk on the combination therapy and the control of myopia, results of 2-year follow-up in the Polish population. The second speaker is Professor Pei Cheng Wu from Taiwan, who will speak on the strategy of myopia intervention affect the prevalence of reduced visual acuity school children in Taiwan. And the third speaker is Dr. Imran Jawed from Nottingham University Hospitals in UK, who will speak on the contact lenses in myopia. Then we have a discussion. So please remember about sending the questions on the chat. Let's start, please.
Hello, my name is Joanna Przeździecka-Dołek, and today I would like to present the results of a combination therapy for myopia control at the 2-year follow-up. The basis for conducting myopia control is the correct assessment of myopia, the correct qualification to a specific group of patients, and the proper assessment of the opportunities that our pediatric patients will have. We should conduct such an evaluation in cooperation with an optometrist, or preferably in collaboration with optometrists and orthoptists, since some children will require visual rehabilitation or accommodative training. We must also take into account during the qualification visit, the measurement of refraction after cycloplegia. In our center, we use cycloplegia as a cyclopantolate administered 2 times every 5 minutes, and we examine patients 20-25 minutes after the last administration of the drug. Each time we have to consider individual needs of the patient. If necessary, we will also provide binocular vision therapy. Sometimes children require binocular vision therapy before atropine. In other cases, we administer atropine at the same time as binocular vision therapy. It is most often just accommodative training. In the case of MyoSmart lenses, everything is happening quite dynamically. We are learning when we are using this type of lenses. We are verifying different reactions, what can be done during the binocular vision treatment. For example, a few years ago, we were saying that MyoSmart lenses would negatively affect binocular vision in children with exophoria to distance, and today we know that a slight exophoria to distance in MyoSmart type lenses, so in lenses where we have the optical zone in the center, is actually beneficial. Well, children have to learn how to aim, how to target the optical zone at the object, and this is quite beneficial because children on their own train before using glasses. They don't need any additional exercises, so this binocular vision training is just, targeting the most comfortable zone, provided that glasses are well made. So the eye moves to the auto position, and that's enough. It's enough. And conditions of therapy are also changing dynamically. Please remember about it. Please always stay up to date with what is currently being reported by opinion leaders or specialists who have many patients wearing particular types of lenses. The aim of the study were so-called primary and secondary endpoints. Primary endpoints included inhibition of myopia progression or slowing down myopia progression. When we were designing the study, it was very popular to talk about inhibition of progression of myopia, and now we know that it's impossible, that we can only slow it down. We also wanted to get the eyeball growth defined as normative in normative basis. Normative basis take into account child's age and gender, change in refraction or change in axial length. An eyeball defined as progression will be assessed as primary endpoint as well. The secondary endpoints included group analysis, including the analysis I have already mentioned. So we specified the group that was originally considered as an unfavorable group, so children with slight exophoria to distance, which is suitable first for treatment and later for glasses. Now we know that we can use glasses right away. The patient's tolerance of a particular method and the final axial length and refraction error. So all these parameters were taken into account. The study was performed and it's actually still being performed in real time. So we have patients who are actually qualified not on a dice roll basis, but based on the real world data. All patients that could be qualified like that. A combination of these two methods. So we have low doses of atropine plus myopia control with optical methods. So why do we want to do it this way? We have 68 patients and 68 eyes, and we chose only one eye. It was a roll of the dice, actually, which eye was analyzed, but these patients were all high risk. From the family history of severe myopia complications, but I'm going to tell you about it later. In the family, there were a lot of complications. So the entire family was myopic. For example, the grandmother was blind because of myopia. There was a case of retinal detachment in the family. The family is therefore aware of the consequences and wants, even if there is a small refractive error, to slow down the progression of myopia as much as possible. These are very conscious family, not many of them right now, but I think that there will be more of such families in the future, families in which parents and grandparents know exactly the problem of myopia. They are totally different type of patients. You talk to them in a different way because they are very aware of the myopia risks. That's why they're also quite afraid. And we also need to take that into account. We shouldn't add any more stress. The group with atropine consisted of 21 children, and despite the fact that low dose atropine was used, we didn't get satisfactory suppression of myopia. Still, we had progression between 0.5 to 1.25. We observed these children for 1 year before inclusion into the study. The untreated group with no previous myopia control had been observed previously for at least 1 year. As I said, they were observed because these children were from families with a high risk of complications, and children were included immediately into a combination therapy. So these were children who had a family history of really severe myopia complications. That's why we opted for combination therapy right away. What about the entire study design? MyoSmart lenses were added to the group of children already using atropine, or we implemented low-dose atropine and MyoSmart lenses. The follow-up time was 2 years, and follow-up examinations were performed every 6 months in the case of other treatments. For example, if there were other eye disorders such as visual impairment, exophoria, or accommodative disorders, in such a case, the children were followed up even more frequently. In most cases, if a child was given any recommendations for home exercise, they had to be followed up for a maximum for 6 to 8 weeks. Why? This is the standard time. We took the child's age in years and we changed that into weeks. If the child is 4 years old, then the results of the treatment should be visible at least after 4 weeks. If the child is 8 years old, we observe the child for no longer than for 8 weeks. What did our group look like? So the patient's characteristics, the average age was 7.5 years and it ranged from 3 to 13 years. Even if the children were over 8 years of age, if they were undergoing visual rehabilitation, we wanted to see them for follow-up visit no later than after 8 weeks. However, we prolonged this period. If these exercises were continued or they were modified in some way, we extended this period to 3 months, but we want to have the primary result after a maximum of 8 weeks, even for 12-year-olds. The average spherical equivalent was minus 3.5 in both groups, ranging from 1.0 to minus 6.5. The average axial length was higher than that in young children. But please remember, these children are of high risk. Here, the genetic factor was very, very strong. Each participant has a high family risk profile. It means that myopia complications are really prevalent in the family, including blindness due to myopia. In our study, we used percentile grids, but we didn't use percentile grids uploaded into the device, but the grids presented by Tiedemann. And for this reason, well, it was for this reason that it was easier to talk to the parents. In these children, this is problem of myopia in these children is prevalent in the family. There is always something going on in the family, and the percentage of risk of high myopia from such percentile grids were helpful for us to communicate with patients and with their families, with the parents. We just wanted to be able to give them specific information, what it would look like in the future, what are the chances of high myopia and high axial length. So it was important for us that these percentile grids had a greater clinical importance to the patient than the grids that are already default in the devices. We all know that we have in biometrics such percentile grids. We have them in the ready-made in all devices. But as I said, it was important for me, how should I explain it to the patient? What percentage of the problem will affect the family and the children? What will be the risk of the odds for this particular family and for this particular child? That's why I chose such percentiles. What about the axial length examination? We want to be within the axial length standards dedicated to a specific group of patients. We have to remember that they're not all the same for all groups, so it's easier to use grids than fixed age ranges. But in the office, if we have only grids, it's quite easy. We put the data to the grid and we have then the grid. But if we don't have percentile grids, then we have options to use different publications, and then we have age ranges with the average axial length of the eyeball. And we take the data. Of course, it would be great if this wouldn't exceed 26 millimeters, because we know that in the young adult population, an axial length of more than 26 millimeters will be already assessed as one that carries serious structural consequences in the retina. What does it look like in these children? We have a group with atropine. Even at the very beginning, the axial length of the eyeball placed them in the group of patients with potentially high myopia in adulthood. this was a really group of high risk. This is a unique group. We usually have a group that is not so at high risk. And here, that was a high risk group, extremely high risk. The same with the untreated group. These were the children that are at high risk. That's why we don't have many of them. They were even younger than 5 years. We had a 3-year-old patients, 4-year-old patients with already high myopia, and these children had already long eyeball. And of course, there was a problem of myopia in their family. What about measuring risk factors, calculating them? How did we take them into account? One parent with myopia was 1 point. 2 parents with myopia, 2 points. Myopia in siblings, 2 points. Complications of myopia in the family, for example, Fuchs spot, glaucoma, myopic maculopathy, 5 points. Blindness due to myopia, for example, if there has been retinal detachment and the eye was blind, also 5 points. And myopia occurring in the further family, here we count every family member, a sister, mom's sister, dad's sister, everyone. Please see that our examples are children that actually, well, had a lot of these points. They collected a lot of such points. If, well, they were of high risk. That's why we already used combination therapy. We didn't use single therapy, or we didn't added lenses to atropine treatment. Observation of refractive changes. During the first 6 months, and this is crucial, as many as 3 eyes required addition of a stronger atropine. Their progression was greater than half of a diopter of spherical equivalent, and unfortunately, it was in the case of 3 eyes, and then again after 2 months in case of 2 eyes. Unfortunately, we still observe more patients that when we see that this is very important, what's happening at the beginning. If in the first year we are successful to suppress the progression, then in the following years, the chance of progression is lower, is significantly lower. It all depends, of course, on the time of the progression. If, for example, if we're between the child's age, between 7 and 14, or if the child is older or younger, the tendency is that younger children have progression that is happening earlier. The younger the child, the earlier we will see this conversion to a greater refractive error. We have young patients like that who came to us as a 4-year-olds. They had increased in myopia progression. For example, the girl here. And she had progression at the beginning, but then there was no major progression after that. So we increased the dose of atropine and nothing happened. At least nothing happened until now. We are now after 2 years, so she's taking 0.5 concentration of atropine and her progression is stable. But will it be stable in the future? I cannot tell you that. We will see what will happen. Today, we have good 2-year results, and I'm really, really satisfied. But here, something very interesting is happening. Something very interesting happened after 18 months in the axial length. When we saw that, we were surprised and we thought, whoa, the eyeball is shorter. No, this is not what actually happened. Children who are treated with atropine or with optical methods, in our case, MyoSmart lenses, well, after 12 months, we observed the peak of progression. And after that, but of course, we need to have a trained accommodation. The accommodative shrinkage disappears, and only then we can see in full biometry that the lens which was previously very thick, tight, and contracted, then after 18 months is actually retracting back and it's thinning. It's not this eyeball shortening. The eyeball is not shorter. It's impossible. But in fact, because this is an optical calculation done by the device after 18 months, practically in every patient that we treated, we see shortening, or this is just a big study error. So please note that if you have only biometry, please don't worry if after 6 months there is little more progression, after 12 months the same situation, but the progression is still within the normal range, and after 18 months the eyeball is shorter than it was originally. But as I said, it's not shorter. It's impossible to do. This is the moment at which the accommodation lets go, disappears. That only then we have only full release of accommodation with the combination methods. So all methods allowed to release this accommodation. We don't see this in refraction very much, most likely because we tend to work, that children work at close distances, but in ATOM 1, ATOM 2 studies in refraction after 6 months, it happened that there was shift to hyperopia. Suddenly the children's refraction error was changing. There was a shift of the arrow to the plus. It was quite characteristic. In my observations, I didn't notice that. Children say they still work a lot, they do still a lot of close-up work, so it's most likely the matter of that. But still, in biometrics, we can observe this. In biometrics, well, we are within normal growth for all patients who were included in the study. Okay, conclusions. Please keep in mind that 75% of patients, so a majority of patients will definitely require some kind of intervention in binocular vision. Sometimes these are home exercises, nothing more. On the other hand, sometimes there is a need for vision rehabilitation. Please also remember that we need to observe patients for up to 12 weeks maximum after implementing home exercises. Ideally, the first exercises should be done in weeks 6 to 8, and then we can extend them to week 12. And let's also remember that combination therapy is safe, but it has to be therapy that is an informed therapy. We all need to know that we are playing to one goal. Parents should be aware of it. We should get the best result for the child. As I said before, we have good results. So 5 eyes had to be administered with high doses of atropine, only 5 eyes, and nothing more. The average progression in 2 years is 0.75 to 1.25, which is below what is considered clinically significant. Thank you. Have a great day.
Ladies and gentlemen, Dzień dobry. It is my great honor to be invited by Professor Gospodski to have this talk. Today, I would like to share with you about the strategy of myopia intervention affect the prevalence of reduced visual acuity in Taiwan school children. I'm Pei Changwu from Taiwan. I'm a retina specialist. Myopia is a global important health issue. WHO has defined and warned the high myopia as -5 diopter or greater can cause serious sight-threatening complications such as early cataract, glaucoma, retinal detachment, myopia CMV, and maculopathy. So who will be the candidate for the high myopia? The answer is our children, because once they onset myopia in early age, the myopia progression is fast. Then they have the high risk become high myopia in the adulthood. So the Taiwan government has noticed that myopia is a serious problem, especially in children. So from 1980s, 30 years ago, the government initiated the enhanced important measures of student vision care program to request the school nurse to perform the student vision screen as the routine in each semester. From 1986, the Department of Health supported Center of the Vision Care in 5 medical centers begin myopia prevention and treatment every 5 years. The epidemiology study of refracting status from 6 to 18 years students in Taiwan were performed. So every 5 years, we can get the psychoplegic refraction by sampling in Taiwan's population. So till now, the Taiwan School Children Vision Care Program is still ongoing. The main purpose is prevent the children become myopia. So the most important screen is the vision acuity screen and the referral in Taiwan educational system. For the unaided visual acuity, is a simple could perform in educational system. It is widely used to approximately detect myopia in school children. In Australia's study for the children, unaided visual acuity screen has higher sensitivity and specificity to detect myopia, over 97%. The correlation between unaided visual acuity and myopia, the index is very high, up to 0.992 in Chinese children. So in Taiwan from 1980s, school nurse perform unaided visual screen every semester. If their vision decreases to 20/25, then refer to ophthalmologist for further diagnosis and treatment. The school will ask the children and parents to bring a referral form to ophthalmologist to be signed and fill up the reflection and the treatment and then bring back to school. "20 years ago, educational system had done several measures to prevent myopia in school and the students, such as promote the gaze in the distance during the recess and doing the eye exercise during the recess, and in the classroom, change the table height to prevent too close reading and writing, and also changing the light up to a certain light intensity, such as 500 lux, were performed. However, such several measures to intervene from 2000 to 2009 but the prevalence of reduced visual acuity in 1 million primary school children in Taiwan still increase. It means the myopia prevalence in school children is still increased. So the many teachers and many administrators in schools very distressed and discouraged. So I had a chance in Vision Care Advisory Council in Ministry of Education in 2009. From the domestic and the international study shows that outdoor activity could reduce the prevalence of myopia in children. Therefore, I strongly suggest that outdoor activity should be implemented in school children vision care program according to the evidence. And we have done several studies to prove that outdoor activity is a protective factor. The earlier one is the races outside classroom, named the rock study. It encourages school children to go outside during the races. This is the first study using educational policy to intervene myopia. It increased around 80 minutes per day outdoor time if we sum up the recess time. After 1 year, this study showed that recess outside classroom could significantly decrease the myopia shift 0.25 diopter versus 0.38 diopter. And it significantly decreased the new onset of myopia, the myopia incidence, over 50%. In the intervention school is 8%, versus to non-intervention school is 18%. This effect is especially effective in non-myopia children to prevent myopia onset. In the meanwhile, the two initiatives called the first is citizen physical activity that promote an additional 150 minutes exercise time per week, named SH150. And the other in educational system is 10-10-120. It encourages outdoor activity 120 minutes every day for myopia prevention in school system in Taiwan. This is the situation that school children go outdoor during the recess. Thereafter, another large-scale study is a nationwide school-based class-wide cluster randomized trial named ROCKED 711. The result after 1 year showed that spend 11 hours or more outdoor a week could have 54% lower risk of the rapid myopia progression. Not only in the prevention, for the control of myopia in myopia children, enough outdoor time could have 30% efficacy for myopia control. Another important result showed that we don't need the strong sunlight, just only moderate light intensity, such as in hallways or under a tree. With enough time outdoor, with moderate light intensity, could achieve myopia prevention and the partial control of myopia progression in myopia children. In Taiwan, almost every primary and secondary school is according to WHO Health Promotion School. So in this very complete system to promote health, we implemented the eye care program in that, including awareness of myopia is a disease, promoting time outdoors, increase time outdoor to prevent myopia, and near workplace, and also referring to eye doctor is also important to monitor the myopia refraction progression. So from 2011 and thereafter, increased time outdoor is an important implementation in eye care program. So thereafter, the prevalence of reduced visual acuity in 1 million school children in Taiwan shows that decrease every year and continuously. It is first time to reverse the status of the policy of the myopia prevalence. So it encourages us to continue this policy. However, during the COVID-19, increased time outdoor is still difficult and not so easy to implement. And from Eastern and Western countries data showing that most of the countries, the myopia prevalence in school children is jumped to very high prevalence. But in Taiwan, because the awareness of myopia is a disease and continue to myopia treatment by eye doctor, and also still promoting outdoor activity as possible, the prevalence of reduced visual acuity could be stable, not to increase. So APP is an effective public health promotion approach for myopia in children. The aim is the awareness. To know the children myopia is a disease that we should look is very important. It is not just a refraction change, but the eyeball elongation, and not just only correction by a spectacle. In addition, what is the important protective factor? The answer is time outdoors. Enough time outdoors, 80 to 120 minutes per day, under moderate sunlight, is beneficial not only for the myopia prevention, but also for the partial control of myopia progression in myopic children. P means promotion, such as rewarding students and reminding the parents to bring children to go outdoor, to increase time outdoor is important, especially in cooperation with health promotion system. The other P is policy intervention. It needs a multidisciplinary cooperation. Jinkuye, thank you for your attention.
Good afternoon. My name's Imran Jawed. I'm a consultant paediatric ophthalmologist. Thank you to the organisers for inviting me to speak to you this afternoon on contact lenses in myopia management. I am a consultant at Nottingham University Hospitals in the UK and at Moorfields Eye Hospital in Dubai. These are my disclosures. The one relevant to this talk is that for Cooper Vision. So when it comes to myopia management options, we have several available. And we generally divide these into optical and pharmacological. As a paediatric ophthalmologist, I guess I'm most comfortable talking about low concentration atropine, and that's probably the one that's most relevant to my practice. However, this afternoon we're going to talk about available optical measures such as orthokeratology and dual focus contact lenses, namely the MiSight 1-day. So in terms of our understanding on how this technology works, it's important to understand the concepts of hyperopic and myopic defocus. So when we correct a myopic eye, we can correct the image at the fovea. However, because of the curvature in the mid-peripheral retina or the globe, we know that that will then render that the peripheral retina is more hyperopic, and i.e. the image that we have corrected using the concave lens falls behind the plane of the retina and introduces hyperopic defocus, and this is likely to enhance myopic progression. One way of overcoming this is to use the mid-peripheral part of the lens to introduce myopic defocus, i.e. less minus or more plus, and this will bring the image in front of the retina and create myopic defocus, and this would therefore suppress myopia progression. And since this kind of theory on that stimulated lots and lots of different lens designs, both spectacle and contact lenses, we've now moved on to things like contrast theories and higher order aberration theories, and we see that evolving in the market on diffusion optic technology, etc., which some of my co-presenters will cover in their talks. So let's start with orthokeratology. So this is a reverse geometry design, which was this type of design was first used when we do penetrating keratoplasties and you have a flat central cornea, and this reverse geometry design is very good at correcting the needs of the optical needs of those patients. These are highly gas permeable and they're worn overnight and provide spectacle independence during the day, and that's true for patients up to -4 to -5, and when it gets beyond that, it gets quite difficult to provide complete spectacle independence, and indeed more challenging to fit. You can see here on this design, so you've got touch centrally, you've got pooling in the mid-peripheral cornea, and a little bit of pooling in the edge of the lens there. So this is a good fitting ortho-K lens. Perhaps not what you want in a standard RGP contact lens, but for an ortho-K lens that's pretty good. And you can see this is the kind of topography pattern that you would get down here. So this is at baseline, a couple of days in where you get some flattening of the epithelium, and then a couple of weeks in you get good flattening there, and that flattening means that you don't need to wear spectacles in the daytime, and that's thought to arrest axial elongation. Does it work? Well, Mark Bullimore and colleagues published in 2020 a summary of 4 meta-analyses summarizing the effects of orthokeratology on myopia progression, and found approximately 0.25 millimeters over a 2-year period. So does it work? Yes, it probably does. However, there are risks of rebound. So what happens when you stop using ortho-K, and it's felt that there will be a return of axial elongation, and perhaps at a rate that's faster than previous, but hard to quantify, and the data around that's quite difficult to decipher. There is always a risk of microbial keratitis when it comes to contact lenses. However, the risks are low, and we'll come across this later on. But the biggest problem with orthokeratology, I suppose, is the fact that you need to be quite skilled and knowledgeable in order to fit these lenses, so that limits it to those who are comfortable fitting RGP lenses on a daily basis, and so that's against most pediatric ophthalmologists in the UK anyway. And the second thing is that you may rely therefore on things like corneal topography in order to modify and perfect the lens design for each of your patients, which that additional technological burden may limit how you might want to use these lenses on a wider scale, making it a less favorable approach for a common problem such as myopia. So the next lens we're going to talk about is a dual focus contact lens. So this has been now commercialized by CooperVision as the MiSight one-day contact lens and is licensed to be used for myopia management. This has two treatment zones, which you can see here, which provide two diopters of myopic defocus, which, as we saw earlier, this provides an image in front of the retina and therefore switching off that signal for axial elongation. The MiSight one-day clinical trial ran over 7 years, so it makes it a very comprehensive study and the longest running contact lens study for myopia management. The first part of the study ran over 3 years, and at baseline children were aged between 8 and 12 and were randomized to either a ProClear one-day contact lens or a MiSight one-day contact lens, and there were about 70 patients in each arm. After the 3 years, those that were originally in the ProClear one-day were switched over to the MiSight, so now everybody in the trial is on the MiSight one-day contact lens, and that took them up to the end of 6 years in the trial. At this point, everybody was then switched back to the ProClear one-day if you were on it originally, or if you're on MiSight, switched off the MiSight and onto the ProClear, i.e. your myopia management stopped. And the point of this last year in the study was to look for rebound. And those children, when we got to part 3, were aged between 14 and 18 when we get to kind of the assessment of rebound or whether there's a recurrence when you stop these contact lenses. At baseline, children were about 10 years old, so when it comes to looking for fast progression, they're not the youngest, but it's not beyond the realms of progression. Most children were Caucasian, and then equally at the end of 3 years they were 3 years older, so 13 when it got to the second part of the study where those in the original ProClear were switched over. So let's have a look at the results, and what we can see is, and I'll just feed this through so we can have a look at all this together. This purple arm here is those children that were on MiSight for the whole 6 years of the study, and this orange arm here was those that were on ProClear for 3 years and then switched to MiSight for the next 3 years. And we can see that there is a significant difference at all time points between those that were on MiSight in terms of cycloplegic spherical equivalent in refractive error, and from those that were on MiSight and those that were on ProClear contact lenses. And over the 6 years, on average, children that were on MiSight for 6 years progressed to about 0.9 diopters over that 6-year period. So let's have a look at the change in axial length over this period. So what we can see is that those that are in the MiSight for 6 years progressed less than 0.5 millimeter over that 6-year period. So for 10-year-old children using MiSight lenses, for 6 years, progressing less than 0.5 millimeter is pretty good. And you can see there's a clinically and statistically significant difference at all time points in this study. But what does that mean? So what does this mean? Well, we can see that those children that were on MiSight for 6 years and those children that were on originally in the ProClear had very similar levels of axial elongation, but only they were 4 years apart. So i.e. Those that were on ProClear for 2 years of the study to start with achieved this 0.5 or almost 0.5 millimeters of axial elongation 2 years into the study. However, it took those that were on MiSight a whole 6 years to achieve that same level of axial elongation, and that's a 4-year gain in a key period for eye growth. So you'll remember that the last part of this trial looked at what happens when you get to the end of the study, i.e. you stop using the MiSight. Will you get a rebound? And this has been a problem for myopia management options such as atropine. And we know that the younger you are and the faster your myopia progresses, the higher the risk of rebound. So this is what happened here, and you can see that at this point, so 72 months, 6 years in, all participants were switched to ProClear, and there's very similar changes but no sudden rebound in their axial elongation at this time point. So this led to the conclusion that there is no risk of rebound. However, that has to be caveated by the fact that most of these children were around 14 to 18 at this point, which means that they naturally would have slowed down. And if you look at the trials for atropine, at least, and some protocols that have been published across Europe, you know, when you get to the age of 15 and 16, you may consider starting to wean down your myopia management options anyway. So if you had a young child that was using MiSight, should you not worry about rebound? I'm not sure we can say that, but certainly in older children, if you stop it, then you are less likely to get a rebound. Some retrospective analyses also looked at some models looking at the annual change in axial length for those that are on ProClear and then projected to go forward for as a function of age versus those that are on MiSight, and they found that there's approximately or almost a 50% reduction in axial length annual change between single vision and those that were on the dual focus technology at this point. And the most important thing whenever we consider any intervention for myopia management is wearing time. So if you do not wear your MyoSmart spectacles, for example, or your contact lens options, or you don't put in your atropine drops, then we're going to have problems in terms of control, and that's not a kind of a difficult assumption to reach. So this has been explained when we look at a couple of studies. So this a defocus incorporated soft contact lens design in Hong Kong Chinese children found, so by Hoya, this was found that in this study, the more that you wore the contact lens, the better the control effect. And you had to get 6 hours a day in order to get a 50% control effect. And we can see further evidence of this when we look at the clinical trials for the Stellest lens, which is the highly aspherical lenslet group, which showed that those that were wearing the spectacle design, the spectacle lens full-time versus part-time, there was a almost 50% progression difference in the Stellest group, depending on the number of hours that you were wearing the spectacles, full-time here being at least 12 hours a day. What about the MiSight contact lens? Well, these were worn really well by children across the study. So at 6 months, they're wearing them almost 13 hours a day, and at 6 years, they're wearing them almost 14 hours a day, with a mean wearing time of at least 6.5 days per week. So we know that children like wearing contact lenses, and if they engage well with contact lenses and it's a form of myopia management, it's likely they will get good effects. However, we worry about adverse events, and namely microbial keratitis, and it's very important that we ensure that anybody who does engage with contact lenses does so safely and that we mitigate the risks. However, what we really need to know is what are the risks and are they comparable to those seen in adults? So the REC study, so retrospective cohort study of the safety of pediatric soft contact lenses, and this was a retrospective review of notes across several centres, which we'll look at on the next slide. And they looked at where the primary outcome measure was the incidence of microbial keratitis in children wearing soft contact lenses. So this looked at 2 randomized controlled trials, i.e. the MiSight data, and 7 US community eye care clinics, which you can see scattered across these several states, so Arizona, California, Pennsylvania, Washington, Indiana, and Ohio. And there was almost 1,000 patients, and that included 782 community clinic patients and 181 randomized controlled trial patients. And these children were first fitted with soft contact lenses when they were between 8 and 12 years old, and they were eligible to be included up until the age of 17. And the key outcome measure here was the incidence of microbial keratitis, and that was found to be 7 in 10,000 years, which is very comparable to that seen in adults. In fact, it's about half, or just under half, and about half of that seen in orthokeratology from children engaging in orthokeratology for myopia management. We also found that the incidence of other adverse events such as contact lens papillary conjunctivitis and associated red eye and peripheral ulcers was also quite low and comparable to adult populations. So as a pediatric ophthalmologist, I tend to use silicone hydrogel soft contact lenses for aphakic pediatric patients following lensectomy, and whilst the incidence of microbial keratitis in our practice is vanishingly low, and that would fit with a REC study, what we do sometimes see is other changes on the ocular health. So when we investigate this using the MySight 1-Day, we need to know that is the ocular health and safety profile of the hydrogel daily disposable contact lens, is it comparable and safe? And this was done through this study, again using the MySight data, so baseline children 8 to 12 years old, all new to contact lenses, and safety assessments were carried out at the slit lamp at week 1, 1 month, 6 months, then every 6 months. So let's have a look to see what that showed. So we can see in total there was over 26,000 total observations, but no evidence of any hypoxic changes from biomicroscopy, and very, very low rates of limbal hyperemia, tarsal hyperemia, and conjunctival or corneal vascularization. So all very positive findings. And through the study, we found that there was one serious event which was not contact lens related, which was herpes zoster uveitis, and 2 episodes of new peripheral corneal ulcers or scars, but they continued their contact lenses. The vast majority of the adverse events were non-significant, and up to 45% were not contact lens related. Throughout the study, there was 4 corneal infiltrative events, which leads to an incidence of about 0.6 per 100 years. So through these 2 studies, we can see that the incidence of corneal infiltrates is low and comparable to adult data, if not better. And there are low and comparable, if not better, evidence of microbial keratitis. In fact, through the MySight study, there was zero episodes of microbial keratitis. And so these results support that children aged between 8 and 18 can successfully wear hydrogel daily disposable contact lenses over a prolonged period of time with minimal impact on ocular physiology. So in summary, we know that contact lens options are effective strategies for myopia management. Wearing time influences control, and so it's really important that we use a modality that children are going to engage with and feel confident and comfortable with. And the fact that contact lenses allows spectacle independence, the fact that we have encouraging safety data, will allow you then to have confidence in the fact that you can utilize these modalities as optical means of achieving myopia management for your patients in a comfortable and positive way. We also know that there are evolving evidence base for combination therapies using low concentration atropine, for example, and this is an exciting area going forwards. So I'd like to thank you so much for your time. I'm happy to take questions. Thank you.
Thank you very much for the very interesting presentations. We are open now for the discussion. This is the comment to the attendees. Please put your questions to the chat. Well, let me start with the Pei Cheng. Thank you for your comment in Polish. I mean, you nicely started and finished with the Polish saying. It is very nice of you. We have a question. well, we see it during the discussion. Yes, let me check. Find Professor Kaimak is with us here also. He asked the question, Hakan, do you want to ask it by yourself or you want me to read it?
You can read it if you wish.
Yeah. So the question is to Pei Cheng. I mean, how bright should be the lighting system in the classroom? How many looks do we need in the classroom constantly?
Thank you, Professor Andres. In about 20 years before, in our education system, our classroom lighting is important issue that they require every classroom in the lighting system should be around 350 lux. But recently they increased to 500 lux as a standard requirement. Previously in China, they had a paper showing that increase the lighting in classroom would have some benefit for the myopia prevalence to decrease a little bit. But in Taiwan's experience, just only lighting system change. I think it may play a certain role, but outdoor activity is more important. Thank you for the question.
Okay, just one comment, because the recommendations they are based on the working place for adults. This is in Europe 500 lux, and it's not for a recommendation for children. So the basis of the recommendation is completely wrong, I think, for the children in Europe.
As I know that in Europe, because after 2016, the lighting system will change into the LED system. So the blue light would be more strong. So I
But it's
remember
still 500. It's still 500 lux. So do you recommend 1000 or 1500? What do you recommend?
Oh, in Taiwan, our education system just only 500 lux.
Okay.
Yeah.
I would like to put maybe a question: is do we have the evidence that higher intensity over 500 will bring any significant benefit in the myopia control? Do we have evidence for that? I mean, from let's say human studies.
As I know, in China, it's difficult to get the children to go outdoors, so they building the glass classroom. But it is very expensive building the glass classroom, so they want to bring around 50,000 lux. 15,000 lux to into the classroom. But as we know, if you reading or working on a working place, if the artificial lighting over such as just mentioned that over 1,500 lux, you will feel very discomfort. So artificial light may be not so so strong, but we still need to exposure to the outdoor nature light may be better. And also some committee in Europe, they also suggest that for the kindergarten children or a far care patient, they needed to prevent the LED light because there is a lot of blue light. So maybe then maybe harmful for the retina or the lens.
Okay, any other, let's say, comments about artificial light? Because, well, finally, as we know, outdoor activity sometimes is not very easy. I mean, because of the seasons, not everywhere. I mean, well, during the winter or time or let's say fall before winter, we have access to the daylight, and because at least because of that, the opportunity to have the artificial light well effective in myopia control could be quite let's say interesting. But the question is what we know about it now. I mean, this is my question.
Yeah, outdoor activity sometimes is difficult to implement, but it's not only beneficial for the eye, but also for increase the vitamin D absorption. Maybe it's beneficial for the bone density, and also it will induce more endorphin for your brain, and you will feel more happy and increase the social skill for other person. And also if you go outside, you will not very long turn to sit to decrease the circulation in your lower body. So I think it's a lot of beneficial, and it's a very easy and simple and no charge free. You can get the beneficial. But for the myopia children, not only outdoor could inhibit the myopia progression, because our study just showing 30%. So it should be combined other treatment. And but I think it's a very good behavior management using the outdoor activity. And then in addition, maybe the other dampening the risk factor, such as near work breaks, to decrease the risk factor stress.
Pei-Cheng, you did mention also about the reading distance. How do you control a reading distance?
Yeah, in Taiwan, previously many some teachers, they were suggesting that at least 30 meter is a good reading distance. But I think even though you have very short reading distance, you needed to have breaks. Such as in US, there were 20 and 20 rules, such as 20 minutes and 20 second, 30 minutes. It is just like that. In Taiwan, we were 30-10. It's 30 minutes near work with 10 minutes breaks.
So the class lasts only 30 minutes in a school, because well in Poland, for example, we have 45 minutes for a class. So I cannot imagine that we interrupt the class for 10 minutes. So it must be shorter, yeah?
In Taiwan, every class is around 40 minutes. So the teacher, they don't ask the children to writing or reading all the time, because they will have duration for the looking at the blackboard, not only just only reading or writing.
So this break is included to the, let's say, class? Yeah.
Yes, there are requirement. It's a requirement.
Okay. Yes, Hakan, please.
There is a recommendation from Hermann Cohen 150 years ago where he recommend the lessons should be 20 minutes. Because what the teacher will not teach in 20 minutes, he will not be able to do it in 40 minutes.
Okay. And so finally, do you control the near distance or not control? I mean, because you mentioned that, of course, I understand that this is general recommendation. Light luminance can be controlled, but what about the reading distance? Is there any method to control it or not? No.
I think it's a little bit difficult, but just a concept to let the parents to know, to help them to maintain a good distance. As I know, in China they had a bar
Yeah,
in a
they have.
ship,
Why I'm asking.
but I think
Sure
it's
about
very difficult.
yeah,
Just
they have methods
but
to control it in China, but that's why I'm asking
yeah.
to do.
Yeah, but nowadays I think because most parents have a smartphone, so it's very easy to set the time out, just 30 minutes or just 20 minutes to get the children to get up. I think it's better to do that, but
Yeah,
distance a little bit difficult.
yeah, but you mean screen time. I'm speaking about the reading distance. It's a different topic, yeah, a bit. And what about the table height? You mentioned about the table height. Why you care about that?
Because the previously the myopia intervention is just from the expert opinion. So they think that the reading distance. So because every children the height is the variation is very big. So they change the table height to let the children to have the 35 centimeter distance away from the table.
Thank you. Well, if you follow the trend that you presented, soon you will have no myopia in Taiwan.
It's still a challenge because the digital learning. So nowadays, every student they have a tablet, and the other challenge is that the climate change, the temperature is higher. So every classroom has an air conditioner. So it's a little bit harder for us to require the children to go outdoors. So we still advocate to the government that maybe every day, if we have the one PE class every day, if it is possible, it's better. And a very strong requirement to the children to go outdoor during the races. And I think there are some challenges there in the world in our future.
Thank you. I have a question to each of you. I mean, more practical, probably question now about the, let's say, proportion of different myopia control methods in your practice, because we have been presenting this session, the combination method, contact lenses, and previous session was atropine and red light therapy, which is not probably available in many places. So let's start with me. In my practice, it is about 50% of atropine and 50% of eyeglasses still. Reverse, I would say 50% of eyeglasses and 50% of atropine still, because I still have a lot of children that I started atropine and some years before eyeglasses were available, but probably today this is the first line therapy for me. I would be eyeglasses. What about you? I mean, let's start sharing this maybe with the Dr. Dowick, please.
Hi, in my practice, I've got contact lenses, ortho-K, and glasses and atropine. And the percentages varies because you cannot put all the patients in the same basket. Not all the patients are best fitted for each procedure. So at first, around 30% of person can be fitted with contact lenses or with the ortho-K. 70 not, probably, or the effect will not be as good as I would like to be. Okay, and after this kind of division, the other that are better fitted for the glasses, they're normally, if they got low risk factors for the glasses, this is the first line therapy, and if not, if they are not fitted for the glasses due to, I don't know, family risk or anything else, they're going for the combination treatment. In the recent year, I've got more on the contact lenses because there are more contact lenses that can be fitted with the myopia control techniques. We've got now newer, maybe, because accommodation, because astigmatism can be fitted with it. We, in soft contact lenses, astigmatism can be done in some kind of constructions. So we got a lot of patients that started with the glasses, now converted to the contact lenses, and still got the atropine. So this is.
Let me summarize. I mean, what I understood: 30% for the contact lenses, and the rest, 70%. How it is? What is the
30% for the standard contact lenses, my side, because they're only the spherical equivalent. Yeah, because
okay. I mean, just make it short. I mean, 30% for contact lenses, and for the rest, 70% is what? I mean,
for glasses, or if they want, for ortho K, because in ortho K you've got a bit more of the astigmatism percentage that you can fit within with success. Yeah, because the topography allows you to do so.
Okay, thank you. Now, Imran, please share your experience.
No problem. So firstly, thanks for inviting me along. My practice in the UK is slightly different, I guess, from other places in Europe, in the sense that we have quite an established optometrist workforce. So most optometrists will perform a sight test, check the fundus, and initiate some optical interventions. And that's growing. So we have predominantly Miosmart and Stellest will be the kind of first line spectacles, and that's what most children would move to. My sight's available, and a lower percentage would use orthokeratology. In my practice, so I'm a pediatric ophthalmologist, I tend to see those patients who have either themselves researched about atropine, because we don't have very many compounding pharmacies, we don't have much availability of atropine. So my preferred concentration is 0.05, so that's what I use as first line. Obviously, when you start on that, you know you're going to be on that treatment for a number of years, up to the age of 15, 16, if you follow Caroline Claver's kind of pro forma, and that's kind of what we do. So if you've got an 8-year-old and you're telling them that you're going to be on it for 7 years, you have to remember in the UK that costs £80 to £90 per month. So it's financially disincentivizes atropine a little bit. Maybe in the next year or so we'll have some more commercially available and cheaper formulations which will change practice. So I have to say primarily it's optical interventions, and primarily that would be Miosmart or Stellest. A smaller percentage using the dual focus technology like MySight, and then a lower percentage that are on long-term 0.05% atropine. That's the kind of split that I've got in my practice.
Thank you so much. And then Hakan?
I think you will see it in my presentation, but I start with the Miosmart classes. And when I have young children with high myopia, then I start with the combination therapy. And when there is a wish for independence of glasses, then I think about multifocal contact lenses with high addition.
Thank you. And Pei Cheng, please.
Because the atropine is very available in Taiwan, so I would use the atropine when they maybe minus 0.5 diopter and also pre-myopia. And thereafter, if they need optical to correction, we will discussing with the parents, such as just like shared decision making, to choose which optical intervention would be added, such as also keratology or subcanal lens or the DIMS. So this will in maybe minus 1.5 diopter after or greater. So now that we have many weapons to use, and if we combination with optical, the concentration of atropine will be lower. is my clinical practice. Thank you.
Thank you, everybody. We must move on and go to the next session. So thank you again for your great presentation and very interesting discussion. Now we need to start the section, finally the last session for today. Yes, and I would like to welcome speakers in this session. The first speaker will be Mr. David Kern, who will speak on myopia management guidelines supported by Myopia Navigator. Then Professor Hakan Kaymak, who was with us during the discussion from Germany, will speak on how do I diagnose and monitor myopia control. Then Professor Mohammed Hassan Imamian from Iran, who will speak on AI in myopia detection and control, update 2024. And then Professor Park from South Korea, who will speak on what changes occur in the optic nerve head of myopic axial elongation in children. Then we have again a short discussion, and finally our conference will be closed. Let's listen to the presentations now, please.
Good afternoon, everybody. Thank you for being here and listening to the presentation. Today, it's about myopia management, obviously, with the Myopia Master. Some of you might heard about the Myopia Master instrument, and I'm sure everybody of you heard about Oculus. On my first slide, you can see our stock. And in this stock, all the instruments, all the pieces, all equipments we distribute, we manufacture the instruments with are actually stored in this building, and this is the biggest visual acuity chart in the world, and we actually have the world record for that. There are 12 megatrends. Megatrends are forces which change our life tremendously. One of this megatrend, and that's where we focus at, is health. And if you look back 10 years, 20 years ago, you can see a big change in health industry. So there's much more importance from the people to health in general. And today we look at the eye especially and the health of the eye. But before we do that, I would like to introduce myself. My name is David Kern. I'm Master of Science in Ophthalmic Optics and Psychophysics, and I'm the head of optometry in product management. This is a normal eye. A normal eye has a good visual acuity, and this is what everybody would like to have. So this is our principal target. And the visual acuity should remain as long as it can. So we would like to have a good visual acuity until we are 90 years old in the best conditions. We know that a normal eye is 24 millimeters long, but we also know that the longer the eye is, the higher the probability to get secondary eye diseases. And the 26 millimeters is really the cut where you say, okay, this is really a high probability to get secondary eye diseases like retinal detachments or other stuff. Retinal changes is what you can see here on this slide. I found a study which is very impressive in my eyes because in this studies, young teenagers were investigated below 10 years old, and they had a high myopic refraction, -8 or a little higher. And what you can see is that there are optic nerve crescents in 50% of the cases. So this is the half of these young teenagers which had this kind of, it's not a disease, but this kind of change already on the retina. 50% had white without pressure. It's also not a disease, but it's also a change you can see on the retina, which will probably be a disease in the later times. Number 3 and 4 is actually a disease. And when you look at the numbers, 6% or 4%, I think this is a very high number for young teenagers. They already get eye diseases, and we know that it's not getting better, it's even getting worse. And for this reason, we should actually do myopia management. And in this case, the actual length longer than 26 millimeters was found as a very significant risk factor. But what exactly do we need to measure when we want to diagnose myopia? And there's a very good study. It's pretty old for this modern topic, but the FDA did this study in 2016, if I remember right, and they defined the measurements which must be performed when doing myopia management. And they defined axial length as an essential value, but also the refractive error is extremely important. If you continue reading, you can also see that keratometry plays a big role for myopia management, but the most important two parameters is refractive error and axial length. Why is both important, axial length and refraction? The BHVI published two very important sentences in my eyes. First, an autofractometer is a helpful instrument that provides a rapid measurement of the refractive error of the eye and a benchmark to consider for subjective refraction. Nonetheless, an optical biometer would be valuable for practices specializing in myopia management as a tool for monitoring progression and identifying those at risk of retinal pathology. So in this case, again, axial length greater than 26 millimeters. Precision of axial length via refraction is something I would like to explain you in this content, because what exactly is the difference between both measurements? And we all know that one diopter is more or less an actual growth of 0.4 millimeters. So this is our number we will use for the following calculations. Repeatability for autofraction in children without cyclopentolate is more or less 0.57 diopters. This was shown in the study from Rauscher and all. And the repeatability for axial length in the Miopia Master is 0.02 millimeters. So we would like to understand how can we compare these numbers. And for this, in this case, we are using the formula above. And what you can see is that 0.0 millimeters is around about 0.05 diopters. So the repeatability is extremely good. For this reason, you need to measure the axial length because it has such a high repeatability, but also the refraction and keratometry. And this is what the Miopia Master can do. And it's the only instrument in the world which can measure both, so biometry and refraction together, on top the keratometry as well. It's not only important to perform measurements, it's also important to understand the measurements. For this reason, we provide a Myopia software, which is directly linked to the Myopia Master. First, you start with the measurements, obviously. Then you follow up with the data analysis as point 2 in this case. The data analysis was supported from the Brian Holden Vision Institute. So we are partners and we are working together in this case. Third is the risk identification, which plays also a big role. And the fourth piece is the patient education with the myopia report, which should be always one of the main parts in your myopia management practice. Number 5 is the growth analysis, which is a brand new module, which I would like to introduce today with a little case report. This is the data analysis. In cooperation with BHVI, we have collected our own data to calculate percentile charts. Percentile charts help you to see if your eye is longer than average or shorter than average. And in our case, we have collected different populations. So we have collected Asian ethnicity, we have collected Caucasian ethnicity, we separate between gender, which is extremely important as well. And based on the input in the software, we directly present the correct growth curves, so the correct percentile charts, and we plot your current measurements into these percentile charts. Not only the percentile charts are important in this case, on the right side, you can see a little bar, and in this bar, you can see also a future estimation of the refractive outcome. This is also important to explain to parents a little bit better what exactly is happening and where we are ending up and why we are doing this. And this is also a unique piece of our software, which can be just found in the Miopia software of Oculus. Not only the data analysis is important, what I said before, it's also risk identification, myopia report, but the growth analysis is one of the latest releases we did in our software, and I would like to show you how you can use this in clinical practice. In our case report, we have measured a patient which was in the company for a study. So we have developed the instrument, and she was one of the first which was measured with the Myopia Master, and that was 4 years ago, around about, or 5. The ethnicity was Caucasian of her. She was born in 2011 in March, and she was not treated for that moment. She was 8.5 years old at that time, and yeah, she was participating in the study. 9 months later, I got a call from her father, which is a colleague of mine, and he said, "Oh, my daughter, she's complaining about poor vision. She cannot see good enough anymore." So what we did is of course, we did a refraction at first. And then we understood, okay, she got a little myopia and she was pretty young at that age. So she was just a little older than 9 years. And the visual acuity was good with the correction, and that was expected as well. And the actual length we have also measured. So the actual length, we were just plotting in our percentile charts, and we could see that there was an actual length which is more or less average. But on the other hand, we can see two other things which are very important at that point. If we see the future prediction, you can see that the outcome will be at more than -4 diopters. Why is this the case? We were looking at the keratometry, and the keratometry was pretty steep. For this reason, she had already myopia, even if the eye was not very long for her age. And what you can also see is that the first measurement was much, much lower, and the growth was pretty high. You can see that in this percentile chart as well, because actually we expect that the patients are more or less moving on the percentiles, but she was growing much, much more than expected. And we have developed exactly for this case, we have developed a special tool to visualize it much, much better. This tool is what you can see here. Let's start on the bottom part of it. So on the bottom graph, you can see the actual length over time. So that's a pretty simple chart to understand. But the upper part is the interesting part. The annual actual growth rate can be calculated, which is actually the slope from the chart on the bottom, technically speaking. The annual actual growth rate tells you how much millimeters the eye was growing on a time period of 1 year. So in this case, the left eye was 0.46 millimeters growing and the right eye 0.42 millimeters. This was very much, and you can see that in the background, there's again percentiles of normative data population, and you can see we are in the red area, so we are actually in a very high eye growth, and that was actually expected as well. For this reason, we have decided to do a treatment. We have chosen also K lenses. There's a simple reason. At that time in Germany, you didn't get spectacle lenses. So for this reason, we said, okay, there's anyway no choice. And the father was wearing rigid lenses as well. And so it was easy for her to start with rigid lenses also, because the father could support her at home. Anyway, this is the fluo pattern we have captured, and we had a visual acuity with the lens and without of 1.0 and 1.25, and the refraction was plano. This is the topography after 7 nights. You can see that the right and on the left eye. And after 7 nights, the optic zone was pretty small, but after 12 months, you can see that the topography was stabilizing much better, and the optic zone was getting a little bit larger. She came back several times, and we checked the actual length again and again and again. And after around about 2 years, you can see we have treated all the K lenses. We found that the actual length was growing still, but was it growing more than it should? And you can see here very nicely that yes, it was growing a little bit more than it should, but it was much better than it was before. Before we were talking about 0.46 millimeters a year. Now we are talking about 0.24 millimeters a year, which is much less. So we are in the yellow area, which is all right. But we were thinking maybe we can still do better. And for this reason, we adapted our strategy. We changed from standard ortho-K design to a myopia control design. Here you can see the difference of both designs. Now we look at the myopia design, which is more aggressive and has a small optic zone. And this is the standard ortho-K design, which has a bigger optic zone. It's less aggressive. So a smaller plus powering than with the myopia design. And this is actually what affects the actual growth. So we have a higher hyperopic defocus with the myopia design, and it's more in the pupil area. And for this reason, we expect it to get a better outcome. And you can see in this case, yes, we are in the green area. It's a annual actual growth of 0.03 and 0.09 millimeters a year, and it's a very, very good result. So in this case, we could communicate with the help of this module as well to the parents very nicely and show the effect why she spent more money than she would have spent if she just worn normal glasses, normal contact lenses, or whatever. But it's not only the actual length which is growing, and you can see a beautiful study here. You can see the actual length, of course, is changing over age. You can see on the right side, the corneal power is not really changing over age, and also is independent from any ametropia. But the crystalline lens power is changing, and you can see this in the bottom of this graphics. So the crystalline lens power is actually decreasing. So what does this mean, and how important is that for myopia management? And I would like to show this with our GRASS module. We also released with our myopia software. Our GRASS module is not only looking at the total refraction, it's looking at all components, at all optical components of the eye, the cornea, the lens, and the actual length. And you can see the effect of every single component in comparison to a normative eye. In this case, the Goldstrand eye. So the GRASS module represents, and this is a live case or a real case again, from a 31 years old, where is the origin of the myopia? And you can see the total refraction on the right eye is minus 2.25 diopters, and the actual length is producing a myopia of minus 3.75 diopters. And you can see the value is higher than the final refraction because it's compensated from the corneal refraction, which is a little hyperopic, and the crystalline lens, which is also a little bit hyperopic. So in this case, we can also look closer at the crystalline lens, but also closer at the cornea power, which is also sometimes very nice. We also do an age adaptation. So if there's a child, we cannot compare with an adult eye, and for this reason, we are using children eyes to do an age adaptation. All right, what is the use case of GRASS? We get a quick overview about the refractive components of the eye. We can see if it's a normal development, not only of the actual length. Is there probably accommodation if the lens is producing a lot of myopia? That's the question here. The influence of myopia treatment decision can be also supported from the GRASS module. Because if there's a binocular effect or if there's a big accommodative issue, the question is if a normal peripheral defocus design, whatever it is, if it's a lens, a contact lens or a spectacle lens, is it still helping or is it still working in these eyes? And this is the summary of the Miopia software and the Miopia master instrument. So myopia management is supported from Brian Holden Vision Institute, and apart from the measurements, we also support with the 5-step software. And I've explained you step 2 and 5 deeply, but also the other steps are very important. Then we can also do a refraction analysis with the GRASS module, the Goldstrand Refractive Analysis System. Thank you very much for your attention. I really appreciate it that you were listening to me. And if you have any questions, please let me know. Thank you very much.
Dear colleagues, thank you very much for the invitation and the opportunity to talk about myopia controlling and monitoring of myopia. I would like to start with the physiology of the eye, and here you can see the natural development of the human eye. The distribution of the refractive errors narrows between the infancy and to early childhood during the process, which is called emmetropization, and it was first described more than 100 years ago from Straub. Here you see the refraction development of children, and as you can see here, the process of emmetropization doesn't stop in the infancy, it will go on to the adulthood. So stabilization of the emmetropization is a very important process. If not, school myopia will occur. We know the reasons for disturbing emmetropization. This was really well documented by Hermann Holz more than 150 years ago. This is myopic parents. We know that insufficient light conditions in the classrooms, less outdoor time, too much reading with too short distance, too much homework, long school hours, too few breaks, too late detection of myopia, to lack of school ophthalmological examinations. And you see also the efforts to have a clear distance for reading. And we also know that axial myopia is what causes the pathological myopia, as you can see here in this fundus photos. That means the cause of pathologic myopia is an increased axial length, which result in pathological myopia. So the axial length is a biomarker for myopic progression, and that means that the axial length growth rate is the best indicator for developing myopia. As you can see here in this publication, before the onset on myopia, before the first prescription of any classes, you see there is a gap in the growth pattern between emmetropic and myopic eyes. You will find a difference 2-3 years before the onset on myopia in refraction. So axial length growth rate is the best indicator of developing myopia and controlling, because the treatment goal should be this physiological growth rate, the emmetropic growth rate. When the physiological eye growth rate is a treatment goal, what it looks like? Well, we can look for the 50th percentile curve or for the emmetropic curves, as you can see here from the literature. But the problem with the percentile curves is that we have a difference between the Caucasian and the Asian eyes. And if you just assume that the 50th percentile curves for the Caucasian in this study is the ametropic, nearly ametropic eye growth rate, you see this is really different from the Asian eyes. That means higher axial lengths in Asian myopes are because of different environmental factors. And when they are changing also in Caucasian eyes, that means the 50th percentile will not be the ametropic curve rate in the future. So we have to think new, and I think we have to forget the percentile curves, and we just have to focus for the ametropic eye growth rate. Then another question arises. What is the definition of ametropia? Well, in this publication you see for the refraction, the cycloplasia is mandatory, and the ametropic were defined as being between minus 0.25 and plus 1 diopters. So when we now look for the ametropic growth patterns for different studies for Caucasian and Asian eyes, we see at the first sight there is a difference between the Asian and the Caucasian eyes. But when we are going into deep, you see there is a different amount of studies with different definitions for ametropia. So I think it is now clear that we find the same definition for ametropia. And as you can see here in the different studies, there's a really huge difference between the definition of ametropia. Is there really a difference between the Caucasian and the Asian eyes? Well, different definitions are there for ametropia. If you compare the studies, the non-East Asian are more hyperopic than the East Asian in the definition. And after controlling for refraction, so if we are using the same definition for ametropia, minus 0.5 diopters plus 0.5 diopters, you have no significant difference. It's the same ametropic eye growth rate for ametropic eyes in the Caucasian and in the Asian eyes. So we have a universal, let it say, curve for the ametropic eyes. And there's another really nice publication where they just solve the question, is there a difference between Caucasian and Asian eyes? And as you can see here in these curves, there is no difference. So we have the same axial lengths in ametropic eyes worldwide. So we have to look for the physiological axial length growth rate pattern, and there are different studies, and we just put them all together. And what we just built up was the MMC system. That's the age-matched myopia control system. We just mean that we have different zones. So we look for the annual growth rate, and we have a green zone with the physiological axial length growth rate, where therapy is not needed. We have a yellow zone with a moderately excessive axial length growth rate, where therapy is recommended. And we have a red zone where therapy is strongly recommended. Why this is so important? Just to look not only for the annual axial growth rate, so also for the sex and the age. Here you can see the importance of the age-matched evaluation of axial length growth. So if you measure an axial length growth of 0.2 millimeters per year, this could have a different impact on your conclusion of the effectiveness of your therapy. So 0.2 millimeters in an 8-year-old boy is normal. This is okay, but not in a 14-year-old boy. And what about the inhibition of 50%? Well, 50% could be normal for a 14-year-old boy, as you can see in this example, but it's not enough for an 8-year-old boy. We just implemented the MMC system in the Landstar from Haag Strijk, as you can see here with these different curves. And I just want to share with you example. I would like to share with you one example of the evaluation and classification of the treatment efficacy. As you can see here, in the first year when a child is in my practice, I look for the axial length, and when it's below the 50th percentile, now I would say from the ametropic curve, no treatment is recommended. Then here, after 1 year, you see that the axial length is above the 50th percentile. And now we have the possibility to use our MMC system. That means in the first year there was no treatment, and we have a moderately excessive axial length growth rate. So I start with the therapy. That means first I have the axial length above the 50th percentile. That means above the ametropic growth rate. And I have in the first year a moderately excessive axial length growth rate. So I start with my treatment, and in this case I use the MyoSmart glasses. And after 1 year of treatment, you see, well, it's really hard to see in these percentile curves. Is this now enough or not? Is this good? What is the effect of the treatment? Here you can see clearly that we are now, after 1 year of treatment, in the physiological axial length growth rate. That means now we have a really good success with our therapy. The evaluation of the MMC system, it's not only for the individual case, but also for the evaluation of different studies. So for your own studies or the published data which are available. So we look for the LAMP study. So we did reloading the data. We get all the biometry data and the refraction data of Kali Lang. So what we already know is that we have this randomized clinical study with the myopia control group and the children treated with the DIMS classes. And this was the 60% inhibition of myopic eye growth. After 1 year of treatment with the DIMS classes evaluated with the MMC system, you can see here that we are achieving the ametropic eye growth rate for the DIMS classes. In medium, you are in the green zone, and for the single vision classes, as you can see here, we are in the red zone. We just published the data in the British Journal. That means that we have not 60% of inhibition, we have a 100% of inhibition, a treatment success of 100% in average, when ametropic eye growth rate is the treatment goal. Another important clinical question is, what is the probability to be in the green zone after the treatment with the DIMS classes? We know in average and median we are in the green zone. But what about the individual cases? So 65% of the children are in the green zone, and in the control group you have the probability of 16% to be in the green zone. This is important for the calculation for further studies. And what about the different ages? As you can see here, there are no difference between the ages. That means we have a very high success rate achieving ametropic eye growth with younger children and also with older children. Again, what about the different baseline axial length growth? Here we see no difference between the different baseline axial length growth. In each cases, we have a very high success rate. For the conclusion for the DIMS classes, we can state that the treatment success consists for different ages and axial lengths. 28% of the DIMS children show high axial length growth. They are in the red zone. That means a combination treatment could be considered in these cases. For the single vision lenses, 16% show treatment success without treatment. We have a very high risk of having high axial length growth in the red zone. For the older children, it's nearly 90%. And with high baseline axial length, it's also 90%. The question is now, what should be my consideration for my daily practice? So I take all available studies for the different approaches with atropine, with the DIMS lenses, with the Hall lenses from Essilor, also the dot lenses, the Zeiss lenses with Miopia, contact lenses with high edition and medium edition. And here are the results. As you can see, and it's up to you, you can judge on your own which treatment you consider, which treatment you prefer. As you can see here, with atropine, the success rate is not very high. You have a significant treatment effect with 0.025%, but not really clinical evident. 0.05% could be a better option if you want to treat the children with atropine. For the DIMS classes, as you can see here, there are long results with the studies is up to 6 years, and you are nearly always in the green zone with the treatment. Interestingly, with the Essilor classes, you just achieve the treatment goal in the first year with the Hall classes, not in the second and not in the third year. You see the contact lenses with the near edition, with high near edition, have a better clinical results as the medium edition, and you have a very good results with the MySight classes for several years. For the dot classes, just in the first year, you have a treatment success with dot 1, but not in the second year. My personal recommendation, the first line therapy, is the MyoSmart classes with the DIMS spectacles. In the case of a therapeutic gap after 1 year, I do the combination with MyoSmart and 0.05% of atropine. If there is a desire for spectacle independence, I prefer the multifocal contact lenses with high addition. And if there is a desire for spectacle freedom, it's the Ortho-K lenses. If you wish to use this AMMC system, you can have it for free. We have a web-based tool for your patient. It's very easy. You just need the refraction and the biometry, the current status of the eye, and then you will get the traffic light system where you can see is myopia, is the axial length above the ametropic curve or not. So is there an axial myopia? If yes, then therapy is recommended. We have the classification still in the percentile curves, but that will change. I will show you in the next slides our ideas about this. Then you will get the evaluation of the annual axial length growth with the traffic light system, red, yellow, and green. So you just know, is there a therapy recommended or not? Is this a highly excessive axial length growth rate or not? Or is this just physiological axial length growth rate what you want to have? And then you can see if there is a good response, a super response, or no response for your treatment, and this makes it very easy to communicate with the parents. You also can just see the increase in growth compared to the physiological growth. So it's a free web-based tool for your myopia control for the daily use. You can also have it for individualized myopia management. It's implemented in the LensStar from Hartstrike. In the future, we would like to classify myopia according to the axial length in low, moderate, high and extreme axial myopia, because in all the studies, the inclusion criteria are based on the refraction, and this makes it a little bit difficult to compare the results with the real-life data, as you can see here, because most of the study eyes are low and moderate myopia, but in real life you have this high and extreme high myopic eyes. And as you can see here, in those cases, the treatment success is not very high. It's 25 to 42%. And in the low and moderate baseline axial lengths, you have a higher treatment success. This has a clinical consequence. That means if I have a child with extreme high myopia, axial myopia, I start with the combination therapy, atropine 0.05%, and the DIMS glasses. Thank you very much for your attention.
Good afternoon, ladies and gentlemen. My name is Mohammad Hassan Emamian, and I am a professor of epidemiology at Shahrud University of Medical Sciences in Shahrud, Iran. I'd like to thank the organizing committee of this interesting and important meeting for inviting me to talk about the latest update of artificial intelligence in myopia detection and control. I have a limited time, so I plan to be brief. I'm going to present an introduction, then the current knowledge about using AI in myopia detection and control, then the latest successes and achievements in the last year, and finally a conclusion. You probably know that the global prevalence of myopia is increasing, and it is estimated that by 2015, near 5 billion people will be affected by myopia. Also, the prevalence of high myopia is increasing, and it is estimated that near 10% of population will be affected by high myopia by 2015. Artificial intelligence has been used in the field of ophthalmology, for example, for the detection of diabetic retinopathy, age-related macular degeneration, cataract, and dry eye disease. However, more works are needed for detection and control of myopia by using artificial intelligence. We have two common sources of data in the field of AI in myopia. The first one is clinical data, including refraction, both cycloplegic and non-cycloplegic, visual acuity, binocular vision, eye motility and accommodations, eye biometry, including axial lens and corneal keratometry. Also the data about the outdoor activity time, near work time, and eye health habits. And finally, the demographic data may be used as the clinical data. Another source of data for using AI in myopia is imaging data, including fundus photography and optical coherence tomography, so-called OCT. Fundus photography may be used for the detection of high myopia and also for the abnormalities in the optic disc, including posterior staphyloma, myopic retraction, maculopathy, myopic choroidal neovascularizations, and dome-shaped macula. Fundus photo also may be used for the predicting of refractive errors. Ultra-wide field fundus photo may be used for the detection of peripheral lesions that are common in the myopic eye. OCT data and images may be used for the detection of myopic maculopathy and pathologic myopia. Also, the retinal diseases such as macular hole, retinal detachment, and pathologic myopic choroidal neovascularization can automatically be detected by OCT images. OCT images may be used for segmenting and analyzing the choroidal sublayers. Also, it may be used for detecting high myopia and estimating uncorrected refractive errors. Finally, OCT and fundus photo can be combined to detect the myopic maculopathy by ATN classification. AI applications based on the published article are summarized in this slide. The first application is risk stratification and risk prediction. Screening and diagnosis of myopia is another application. Also, AI may be used for the prediction of myopia progression. Pathogenesis insights can be achieved by AI algorithms that analyze large-scale genetic data, environmental factors, and eye measurements. It may be used for treatment guidance by integration of patient-specific data and treatment options. AI also may be used for discrimination between indoor and outdoor environmental state. In the next slides, I will provide the latest success and achievements of AI in myopia detection and control in the last year, which is the main objective of this presentation. I think the most important and amazing achievement of AI in ophthalmology is RETFund, which is a stand for Retinal Foundation. RETFund is trained on a huge number of unlabeled retinal images by means of self-supervised learning. Now many ophthalmology diseases and also systemic diseases such as myocardial infarction, stroke, heart failure, and even Parkinson's disease can be detected by this means. RETFund provides a generalized solution to improve model performance and alleviate the workload of experts in clinics. RETFund is freely available for all researchers as open source database. I suggest that AI specialists use this interesting platform. Another interesting achievement during the last year is the development of ARAS for detecting multiple fundus diseases in primary healthcare setting. ARAS uses artificial intelligence system with air duct technology. In this table, you can see that the performance of ARAS in the term of accuracy, specificity, and negative predictive value was very high and impressive for the detecting of pathologic myopia and myopic choroidal neovascularization. AI and prediction of myopia progression was the subject of some published articles during last year. In one study, the researcher developed a predictive model for the development of myopia. They used data from the 5 Chinese cohort studies with more than 200,000 participants. They concluded that their model had a very good precision in predicting myopia and the risk of high myopia. In another study, electronic medical record of 88,000 individuals aged 3 to 18 years were reviewed for the spherical equivalent onset of myopia and high myopia up to 15 years after the first examination. They found that XGBoost predictive model exhibited high accuracy in predicting SE onset of myopia and high myopia. In another study, near 3,000 children aged 6 to 16 years from the 2 cohorts in China were used as a training set, and another cohort study in Singapore was used for external validation. The researcher found that cyclopelagic refraction or ocular biometry can predict 1-year risk of myopia. Cyclopelagic refraction showed the best predictive ability. Also, the number of myopic parents was a strong predictive factor. The predictive accuracy of cyclopelagic SE was more than 90% in both internal and external validation cohorts. 3 other studies that use AI for prediction of myopia progression are summarized in this slide. In the first study, researchers analyzed the relevant factors affecting myopia progression and developed a model for predicting myopia progression and high myopia in children. They found again that XGBoost prediction model was the best model, and the baseline SE, BMI, and frequency of eating sweets were risk factors for myopia progression. In another study by Huang et al., SE was predicted on variable length historical vision records in 6 to 20 years Chinese individual. The overall error for this model was minimal. And in third study by Fu et al., a clinically acceptable deep learning model was developed for prediction of 5-year risk of high myopia using fundus images. AI has been used for diagnosing myopia risk factors in last year. For example, in a study in China, AI-enhanced tablets were used for recording behavior of students and environmental light during screen time. The results were very interesting that summarized in this slide. Tong et al. Also developed a myopia classification model for each schooling period. They conclude that the main cause of myopia in lower level students were genetic factors, and for higher level, the behavior of a student was the main factor. AI in intraocular lens power calculation was the subject of other studies during the last year. In one study in post-smart surgery patients, the researcher found that AI-based formula do not demonstrate significant advantages over the conventional formula. But in another study, the researcher found that XGBoost, HEAL RBF, and Kane formula were significantly more accurate than traditional versions formula in highly myopic eyes. And in another study by Kao et al., among the 7 IOL calculation formula, K6 and Holiday 1 exhibited the most significant improvement after integrating of machine learning methods. In another study by Jiang et al., a novel machine learning model was developed for predicting post-operative refractor error and calculating EVO IC lens power. The model had comparable accuracy than existing versions formula, especially for low to moderate myopia patients. AI and refractive surgery for myopia was the topic of other studies during the last year. In one study, the multi-class random forest model showed the high agreement with ophthalmologist decisions. So AI can help ophthalmologists in choosing appropriate types of refractive surgery. Another study compared conventional nomograms for a SMILE surgery with novel machine learning based nomogram. The researcher concluded that machine learning endorsed the validity of novel linear and nonlinear SMILE nomograms. AI and retinal manifestation of myopia were investigated in other studies during the last year. In one study, GBM algorithms successfully predicted the diagnosis of retinal detachment in patients with high myopia. In another study, RUNet and transfer learning technology had good accuracy and performance in quantitative analysis of vascular morphology in retina. Machine learning also helps in differential diagnosis between the two types of subretinal hemorrhage, one due to choroidal neovascularizations and other without CNV. Huang et al. Also developed a deep learning model for automatic detection of myopic traction maculopathy in highly myopic eye using OCT imaging with high sensitivities and specificities. AI in diagnosis of high myopia was the topic of other studies during last year. In one study, AI system based on deep learning show excellent performance in detection of pathologic myopia and CNV, which were comparable to senior ophthalmologists. In another meta-analysis study on 11 studies, a high sensitivity and specificity were reported for detection of pathologic myopia. Another study developed a model to predict visual acuity in patients with CNV. The model achieved high performance in predicting visual acuity after 1, 2, and 3 years. Other studies in using AI in diagnosis of high myopia are summarized in this slide. New et al. Developed a standardized classification system and a novel grading system for detection of diffuse chorioretinal atrophy. Fang et al. Developed PALM, an open fundus imaging database for the detection of pathologic myopia. And Kumari et al. Developed a CNN model for early detection of pathologic myopia with high accuracy, sensitivity, and specificity. Other researchers focused on quantization of optic disc characteristics in myopic eye. For example, one study reported the optic disc area, cup to disc ratio, optic disc tilts, and the area width and height of peripapillary atrophy in myopic eye. Another study reported the nasal and temporal neuroretinal rims and showed that area ratio of the peripapillary atrophy to the optic disc could be used as an early predictor of myopia progression. AI was also used for detection of biomarkers in myopia. LY96 was identified as immunogenic cell death biomarkers. Zhang et al. Identified 23 different genes associated with myopia, and lasso regression and random forest model reported 2 portents of corneal stroma that may be contribute to the pathophysiology of high myopia. This slide summarizes 4 other studies that use AI for myopia treatments. Cao et al. Developed a deep learning-based model for predicting 12 months axial length elongation in children treated with ortho-K. Jiang et al. Reported the effect of wart on predicting postoperative refractive error. And Lan et al. Developed an AI-assisted prescription for ortho-K lens fitting. Also, Ku et al. Developed a machine learning model with high accuracy for predicting ortho-K lens parameters. We will definitely have interesting researches in futures. 2 of them are summarized in this slide. The first one is the CHARM project, which is a stand for China Alliance of Research in High Myopia. CHARM is an established consortium that includes more than 100 hospitals and research centers. In this project, data from the basic information, multimodal imaging, and genetic data will be used. Another study is called Miopia Risk Calculator, which is led by Professor Zibowski from Poland. This project is aimed to develop a web-based tools for estimating myopia onset and progression. The result will be used by parents and also by clinicians. Despite promising results in the field of AI in ophthalmology, there are limitations or challenges. The first one is quality and quantity of data, because AI models heavily rely on high quality data. The disparity of imaging system, lack of sufficient public database and infrastructures, and privacy concerns are among other limitations. AI algorithms often operate as black boxes, which may be considered as important limitations. Transitioning AI from research to clinical practice requires collaboration between ophthalmologists, AI experts, and healthcare professionals that is not available in each setting. This last slide I summarized the recent finding as conclusion. The first conclusion is that AI holds great promise for myopia management, which is actually a good news. The collaboration between AI experts and ophthalmologists is crucial. As another conclusion, most of the studies on using AI for management of myopia were done in China or Singapore. The prevalence of myopia in these countries are very high, so it is necessary to study in other countries with different races and myopia risk factors. AI models should also be validated in different populations. Sharing data international consortium is an important policy for the above goals. And finally, we should always stay updated with the latest research and technological breakthrough. And thank you so much for your attention. I will be glad if can answer to your questions or comments. Thank you.
Good afternoon. I'm Ki-Ho Park at Seoul National University and currently serving as the president of the Korean Myopia Society. It is my great honor and privilege to be invited to the Myopia 2024 conference. I'm going to share with you about the topic, what changes occur in the optic nerve head of myopic axial elongation in children. This is my financial disclosure. There is an epidemic of myopia in East and Southeast Asia. Now the prevalence of myopia in young adults is estimated as around 80 to 90%. The prevalence of myopia in school children is around 80% in Asian countries, of which Korea shows the highest prevalence. It is well established that myopia presents an increased risk of glaucoma. The degree of myopia is associated with glaucoma risk with a dose-dependent pattern. So each unit diopter increase in myopia, the risk of glaucoma increases by approximately 20%. Glaucoma diagnosis and monitoring in high myopia patients is challenging because it is difficult to differentiate between glaucomatous changes and myopic changes. And disc tilt, peripapillary atrophy, chorioretinal atrophy, and eyeball elongation make it difficult to detect glaucomatous structural changes. In 2010 Japanese Journal of Ophthalmology, the changes in optic disc shape and size in 2 patients with suspected glaucoma during a 2 and 3 year follow-up period have been reported. Both cases showed myopic shift after 3 or 2 years, and the deformity was suspiciously related with the myopic change or the glaucomatous change. From our department, a longitudinal morphologic change of the optic disc with progression of incipient myopia has been reported. The temporal disc margin and the central retinal vessels have been shown to move nasally with myopic shift. Using spectral domain OCT, longitudinal changes of the optic nerve head structure during childhood myopia progression has been reported. The representative case showed that the border tissue configuration changed from internally oblique to externally oblique. And in another case, the border tissue length has been increased. Another study by the same group has proposed a LC shifting during axial elongation. The authors concluded that LC along with the central retinal vessels is shifted nasally parallel to BMO opening. So the authors speculated that the LC shift rather than tilt was fundamental to the appearance of oval disc. However, there is a limitation of this hypothesis, as this type of temporal disc margin flattening could not be explained by the simple parallel LC shifting. If the LC is simply shifted, the contour of the disc margin should be more curved, same as the original one. With this background, the purpose of our study was to investigate longitudinal changes of border tissue configuration during axial elongation in childhood, not only in myopic eyes, but also in ametropic and hyperopic eyes. It was a retrospective longitudinal observational study, including 108 eyes of 54 subjects aged between 3 to 13 years old. Swept source OCT imaging was performed at the initial visit and after at least 6 months interval. This swept source OCT protocol captures color fundus photos as well as optic disc scans, allowing simultaneous evaluation and tracking of serial scan images during follow-up at the same location. The axial length became longer in all cases. The refraction became more myopic in most cases. The study subjects were further classified into stable axial length eyes and elongating axial length eyes with the criteria from the median axial length change of the entire study population. The stable axial length eyes were 55 and the elongating axial length eyes were 53. The mean follow-up period were more than 15 months. The age of the elongating axial length group was significantly older and showed longer axial lengths at baseline. In the entire population, the temporal border tissue angle became less internally oblique and the nasal border tissue angle more internally oblique. In the elongating axial length group, the temporal border tissue angle became even less internally oblique, and the nasal border tissue angle even more internally oblique. Brooks membrane opening BMO distance was enlarged during axial elongation. So during the axial elongation, this BMO distance increase seems to be due to temporal stretching of BMO, while the optic nerve and anterior scleral opening were pulled nasally. The nasal minimum rim width was shown to be increased during the axial elongation, which means the nasal rim was elevated during the axial elongation. You can clearly see the nasal rim tissue was elevated both in the cross-sectional and 3D images, which is an indirect evidence of the nasal LC tilting. The nasal neural tissue became elevated and crowded during axial elongation. If we summarize our results, during the axial elongation, instead of simple nasal LC shift, temporal stretching of BMO, nasal LC tilting, and nasal peripapillary tissue elevation occurs. Little is known about the myopic characteristics of lamina cribrosa curvature in adults, so we investigated nasal and temporal LC curvatures in myopia and compared with those in non-myopic eyes, and found that in myopic relative to non-myopic eyes, LC curvature was decreased temporally and increased nasally. In myopic glaucomatous eye, papillomacular bundle is frequently damaged, as shown in this paper from Japan. This may be related with the tractional stress on the optic nerve and lamina cribrosa in the temporal part of the disc. Little is known about the papillomacular bundle defect, PMBD, in highly myopic glaucoma. So we investigated the frequency of PMBD in glaucoma patients with high myopia and its risk factors. The frequency of PMBD in highly myopic glaucoma was 60%. Larger peripapillary atrophy to disc area ratio and LC defect positiveness were associated with the PMBD in glaucoma patients with high myopia. And central visual field defects were significantly associated with the PMBD as well in glaucoma patients with high myopia. In summary, there is an epidemic of myopia in East and Southeast Asia. Myopia is known as a risk factor for glaucoma with a dose-dependent manner. During childhood myopia progression, temporal disc margin and central retinal vessels have been shown to move nasally. BMO and border tissue are pulled temporally, while the optic nerve and anterior scleral opening were pulled nasally. LC curvature was decreased temporally and increased nasally. PPA to disc area ratio, LC defect, and central visual field defect were significantly associated with the PMBD in glaucoma patients with high myopia. Understanding these changes may help diagnosing glaucoma in myopia. Thank you for your attention.
Thank you very much, all the speakers, for great presentations. Two of the speakers from this session are with us. It's Professor Kaimak and Professor Hassan from Iran. Let me just start with a question from the chat. This is obviously the question to Professor Kaimak. How large is your database that the percentiles had calculated from?
This was a meta-analysis from the publication and also our own data. I think our own data must be 3,000 children, what we measured.
Thank you. Well, I have a few questions, Hakan, to you. Of course, you brought with your presentation many possible issues and questions. So, the first question, after Mark Ballymore, maybe you have followed his lecture, but we did have a short conversation after his lecture about that, who should be treated and why. The question for you is, why not to treat every myopic child? I mean, because you clearly shown the when to start treatment and when you don't need to start treatment. And Mark Ballymore shown that, let's say, all myopia is related, or majority of myopia is related with some sort of progression. So why not to stop every sort of progression, since every diopter matters? Sometimes when we treat it, we will have, of course, more benefit, sometimes less. But if every diopter matters, then maybe we should treat every myopic child. Why not to do that?
I think the same. Well, when we look for the axial length, and when the axial length is above the ametropic eye length, then I think we have to think about the myopia treatment. Now with the classes, it's much easier to start with the myopia treatment because 5-6 years ago, we have to think about atropine. Should we give atropine or not? I think it was more difficult, but now with the glasses, everyone should be given the myopia treatment with the glasses, and this should be the gold standard because it's very easy.
Yeah, this is the good point. Yeah, I'm getting closer to that finally after this conversation today. Of course, the only problem, I agree that eyeglasses are safe and non-invasive, well, compared to the previous therapies. But what about the cost? The only problem is cost. I mean,
you are absolutely right. It's really just the cost. And I'm just talking about the medical side. For the cost, you are absolutely right. And it's easier when you have 2 children, giving them the atropine drops with 1 drop bottle for the 2 children than with the eyeglasses. So if the myopia classes are getting the gold standard, then I think the cost will go down. But we have to be careful because not every classes are the same, as you see in my presentation.
Yeah, this is another question I have for you, but I have one more question regarding the cost in Germany. Is it 100%, so totally reimbursed, or it is only no, it is not reimbursed. So the patient cover the cost because, well,
Yes.
it is much different depending on the country. Also in Poland, our patients must pay 100% of the cost. But for example, in France, I remember our conversation with Professor Dominique Bremont-Gignac recently, and when she mentioned that in France it is totally reimbursed. Every finally therapy, including contact lenses, eyeglasses, atropine, everything is reimbursed 100%.
I think it's in Switzerland also the same because they are really poor people and so they get the reimbursement.
Hassan, is it what about the let's say access to the eyeglasses in Iran? Do you have access to the eyeglasses, this DIMS and halls, and is it expensive?
Yes, we have access to eyeglasses, but most of them are expensive, and the insurance company supports some cost, of course.
But I don't know how it's in other countries, but the parents, they get a guarantee if there is more progression, more than 0.5 diopters in a year, then they get the glasses for free.
It depends on the country. It's not probably.
Just in Germany, yes, it's in Germany. That's the case.
But I must share that some of my patients, I mean, prefer to have atropine compared to eyeglasses because atropine is much cheaper in Poland. It is reimbursed, by the way, so it's much cheaper, and the cost matters. I mean, for well, some patients at least. So yeah.
And they trust more medicine than glasses.
Yeah. And well, you mentioned about DIMS several times. So my another question is why you prefer DIMS over HOS? I mean, regarding the technology. I mean, because both of these approaches, both of these technologies are supported by very strong, let's say, studies and evidence. So why you clearly prefer DIMS?
Because I just really start with the DIMS classes. And when you have to collect your experience, you have to focus on one classes. That's my opinion. So I get the best experience. Second, if you look to the chart, you see that in the second year, the effect of the HAL classes were not as good as with the DIMS in the second and the third year.
Well, but I remember
when I'm just looking for the studies, not my experience.
I remember. Sorry, please.
When I'm just looking for the study results, and I look for the study results, and then I decide which therapy I prefer.
Sure. Well, but you started.
But also, I'm a consulting for Hoya and not for Essilor.
That's very good that you mentioned that.
Yeah.
But you also mentioned very interesting point that not all eyeglasses are, let's say, evidence are supported by the evidence. This is also my point because I have noticed recently a few new brands or companies introducing their eyeglasses with no real studies. I mean, as a matter of fact, I've been recently to the meeting in Varna in Bulgaria, and there was a presentation by the company from Italy. I don't remember the name of the company, but they said that they have the same product as Hoya. I mean, as the DIMS, the same, similar, well, construction of the eyeglasses. And when I asked them, do you have any studies showing that they work? They said, why? We don't have it. We don't need it. They work. So this was, well, funny and not funny on the other hand, because it is confusing and probably misleading a lot of people. So what is your opinion about that?
I think really we have to look for the studies and they have to be randomized and they had to be with the placebo group. I think that's very important in the first instance to start with them. And then I think we get our own results, our real data. And we have to be very careful because in the real life. We have much younger patients than in the studies. We have much higher degrees of myopia, and then we get really other results. As you saw in my presentation, the effect of the DIMS glasses in the younger children with high myopia is just 30%. So we have to be very careful. For those, I think it's not working really well. So in these cases, I start with the combination therapy.
Yeah, I have the question on the chat in Polish language. So this is for colleagues, but I will speak in English because the
Thank
whole
you.
conference is being translated simultaneously translated into Polish due to the, let's say, support of the Polish Ministry of Science and Education. So the question, I think it was a misunderstanding, because what I did say is that the atropine is reimbursed, what means it is, well, maybe not completely free, but it's very cheap in Poland. So the question was if the patient must pay 100%. No, I mean we can prescribe it for, well, we have a special form of prescription with the fixed price. This is very low, but or lower than the well, let's say 100%. So, well, in Poland, I'm pretty much convinced that we can use this model. Yeah.
I saw the problem with atropine several years ago, where we just compared the different bottles from the different companies in Germany, and we have this publication together. But I think it's very worth to mention that there is a really huge difference in the concentration, in the formulation, in the pH, in the osmolarity, in the drops. So it's much easier really with the glasses. When we get really the same bottle with the same formulation, then I think it will go very well. And your last publication, I have to mention, we have just calculated it's nearly 80% of effectiveness. And I think that's the way we have to go.
Thank you. Thank you. I completely agree. I mean that the compounded pharmacies are quite unreliable. And of course, all of us who used atropine for last years probably faced many problems with that. So completely agree.
And it might be that you have the best formulation. You are better than Nevercard.
Thank you. But I have one more question about your Myopia web-based platform. This is very interesting. I mean, and thank you for showing that and let's say preparing that and making it available for us. The question is, what, of course, from the, let's say, visibility, appearance, it looks much better than the Brian Holden Institute calculator. But what is the difference in the, let's say, content between these two models?
The model is just I think we were the first to start with this, and we were now developing, but it should be very easy. Just when you have the children or the child, then you do the measurements with the axial length, then you have to get your recommendation. Should I start with myopia treatment, yes or no? And I think that's very easy. And after 1 year, you have to decide, is my treatment right or not? Should I do a combination therapy or just changing? It have to be very safe and very easy. This was the point. And it's not much more than. So we have no calculation for the future, what will be the end myopia of this child. This is not our aim. This is just really of a practical point. Am I on the right way or not?
Yeah, this is certainly much more user-friendly. I confirm that. Certainly recommended. Let's move a little bit to the AI. we still have no more questions, but well, for me, it is very challenging if we can use in the future fundus pictures or OCT scans to predict or to evaluate refractive error. And but the problem is that probably we do not have adequate data sets, because, well, normally we do not take fundus pictures, OCT scans in every child with the refractive error. So how to do that? I mean, Hassan, do you have any idea? Do you work on that? Maybe in Iran? I know that you were involved, you're still involved in many epidemiological studies, and there are very strong studies conducted in Iran.
Okay, actually, this is a good point. As I mentioned in my presentation, in the last year, Red Fund introduced an interesting platform by self-learning with more than 1 billion fundus photo. So I think that this platform can be used for training other databases. And in each country, this platform may be used for predicting high myopia and myopia progression. In Iran also, we try to develop our studies, our cohort studies, or data sets can be used for training. In this regard, I want to mention another point regarding the two technologies that presented today. I think that the new technology for the management of myopia needs more clinical trials with larger sample size and with different ethnicity and different countries to be available in each country. So I think that the works presented in the first two presentations and my works all based on AI. And in future years, I think that AI may integrate in early diagnostic machine in ophthalmology.
Thank you. I mean, this is the great conclusion. And finally, just to remind you that in 2 weeks, we have the AI in ophthalmology meeting organized by our foundation, and also with the collaboration with the University of Armenia and Missouri and Polish Ministry for Science and Education. So if you are interested in AI in ophthalmology general, please join us. There will be a lot of interesting talks, some of them on basics and many much more, let's say, developed. So thank you again, colleagues, for
my pleasure.
joining us today and sparing your time. Thank you. And now we have the time to say goodbye. Thank you, everybody who contributed to this meeting, and all of you who spent with us this afternoon or different because of the different time zones. It could be morning or night for myopia education. I hope that we learned today a lot from our experts. Thank you so much.
Thank you. Bye-bye.
Bye-bye.
Mr.